A very good morning to all the audience. I'm Evelyn Chow, your MC for today. A very warm welcome to part 3 of the third installment of Emergency Medicine Seminar Series, EMSS. EMSS is an educational series organized and collaborated by 3 different countries in Asia, which includes the Faculty of Medicine in University Kebangsaan Malaysia, University of Philippines, and University Brawijaya in Indonesia. Today, we are very honored to have nine bright future emergency physicians from both Malaysia and Philippines to share with us the outcome of their research thesis. Before we move on, I would like to briefly explain the structure of our sessions. So there will be 3 sessions of presentation today. For each session, there will be 3 presenters and 15 minutes will be allocated to each presenters. For the presentations, will flow from one to another without any interruption. For any question, kindly type it in the Q&A box. Your questions will be answered at the end of the session. Second, this is not a competition, but for encouragement purpose, one best presenter will be chosen from each session. Our panel of judges consists of 6 emergency medicine specialists and consultants from the 3 organizing universities. We have some housekeeping rules for you. Kindly mute your mic. For Malaysian, a QR code for MMS CPD points will be displayed at the end of the webinar. Certificate of participation will be given after the webinar. Without further ado, we would like to invite our advisor, Prof. Maya Dr. Ahmad Khaldun Ismail, to give the opening speech. Prof. Khaldun, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Evelyn, for the kind introduction. I will just say that this is our first ever program to showcase some of the research output by our budding emergency physicians from 3 countries, hopefully in the near future. But currently, since this is the first EMSS reviewing about research, we have invited our colleagues from the Philippines to also participate and share some of their experience in doing research and some of their research output. And we will have our own emergency medicine master students in HUKM to share some of their research output as well. Well, hopefully in the near future, this program will be more widespread. I mean, open to more, how should I say, participants. Again, as Evelyn said, this is not a competition. This is actually more of sharing session. So I will just give you a brief overview. Just to give you an overview, as I'm not an expert, but this is how I experience research I would like to share. And hopefully our young ones can take some pointers from this small or short presentation. So, so what is research? Basically, as I have always told my students that it's about looking or searching for new knowledge, something which is not really yet established, and not just finding it, but also after finding it, you need to analyze it well, make a report about it, and then tell the whole world about it. So that what we call as the line of knowledge. At the moment, the line of knowledge is still missing some points on it. So it's not a continuous line. It's always an ever-expanding, non-continuous line. So the research output that you provide will actually complete one dot on the line. So we'll, try to make the line of knowledge more complete. So, for some people, research cannot be forced. It has to come from your own interest. And therefore, for some people, or maybe for some students, I personally have experienced this, research can be very painful. but research can also be very, very a happy, joyful occasion, especially when you get your research published. Okay, so as I have said, research is to generate new concept, methodologies, some inventions maybe, and some understanding about a certain topic that is still not yet understood well in the community or by the scientific community. So another thing about research is actually a form of communication and disseminating new knowledge to other people. And sometimes it's not just new, but to confirm the previous findings. Okay, and as we are doing today, we are actually sharing our expertise. We have our colleagues from Indonesia, from Philippines, in this region particularly, is to share our experience and our knowledge. Knowledge cannot be kept to one person. There's no point. Okay, knowledge needs to be shared. Otherwise, you can't call it knowledge. The more we share about knowledge, the more we will gain actually from it. If you keep knowledge, you will not become richer. Okay, so from this sharing of knowledge and so on, from the research output, we actually will lead human development, okay, through scholarly engagement, evidence-based. So not through conspiracy theory, okay, that we are facing today. A lot of people are talking about COVID-19 and all the anti-vaxxers and so on. They are just, not evidence-based. So we are providing evidence-based, and that's what is encouraged in our own belief or religion. Okay, so in terms of looking at research criteria, there are many. So there are actually a range or spectrum of research criteria. So basically, our purpose in the research is actually either to advance the discipline. For example, our fraternity is emergency medicine. So we are trying to push emergency medicine forward with research. Okay, so that is actually providing the basis for all of our clinical practice. And then we want to build the reputation. So our reputation as emergency physician or emergency medicine is not based on whims and fancies, what you feel or what the BOMO or witch doctors say, but we base on our findings of research and our evidence. Okay, and this actually will lead to the recognition of research excellence in our own fraternity and by others as well. Okay, and another thing why this is important is because it enables our research to be supervised and monitored through what you call a collective intelligence. Okay, not just anybody can actually say anything about research, but we always learn something new, and we get what we call our peers to actually supervise and monitor our output, so that this is actually uh, you know considered as a quality product that we can, or quality information or quality knowledge that we provide to the society. Through research, we actually will form a kind of we cannot do research on our own. We have to work together, and this is one of the other purpose for this particular event, is to find leaders in research, to find research teams, to build research units or in institute or centers, and forestry interdisciplinary research. So we cannot just keep our so-called expertise to just emergency medicine. We need to work not just with us, among us, but also for those with those not in the fraternity of emergency medicine. And I personally, from my experience, I've worked with many others which are non-doctors, which are non-medical doctors. So, but they are experts in their own field, and that kind of our research finding enriches not just in medicine, but also other knowledges as well. Okay, so it is very important that we have to be global in our understanding and thinking about research. Okay, and should not be, keeping things to ourselves. We have to share and we have to work together. So another part of research is actually to translate or commercialize. Some people say commercialize when you sell your product, if you have a product, but it can also translate into practice. So for example, what we find in our research, in clinical research, we translate it into our clinical practice. Okay, so if we research say that this practice is good and should be done, so it helps in our clinical practice to treat our patient better. And adoption of discoveries is very important, because otherwise we will not advance as a human being. So we have to, we will be stagnant. Okay, so we have from our research, is actually we're going to push humanity to a better, hopefully, society in the near future. And in terms of policy to practice, as I have mentioned earlier, and policy in terms of not just in medicine, but also sometimes in governance as well. Okay, that's why we have to consider some of our finding may actually help not just our own so-called emergency, very small-minded, but we have to think bigger than what we need. The society will benefit, the whole world will benefit from our efforts in doing research. Okay, so in terms of research output, as I have to say just now, why we do research is to place our mark in the line of knowledge. Okay, so sometimes what we see today, a lot of us more influenced by what people say. We tend to refer to what other people's findings, which may or may not be relevant to our community, to our practice, to our situation, to our need. That's the reason why it's important to get our say also out there. And that's why we have to do our own research, either to confirm or to find new things, okay, for our need. So you have to have a very good research question that is referring to your need, okay? And that's why we do research, so that we can contribute what our opinion is. It may be the same as what other people say or what other people find or found, but it is important also to have our say, to collaborate or corroborate with what other people found. So research, a good research is sometimes is reproducible. Okay, you have to have, when you reproduce the same research, you will actually find the same finding or not. But most of the time, in terms of corroboration of what other people say is true or not, you will find that yours also will corroborate with what they find. Doesn't mean that somebody else done the research, you should not do it. No, there are always areas and avenues where you can actually repeat the research to your own community and to see whether it finds the same finding or not. Okay, and that will contribute to the line of knowledge. The world is big. Well, some people say the Earth is very small in the universe, but we have to think big. Okay, so so how you start? This is how I start with my own mentees. We basically get in touch together. We have to speak, we have to talk, we have to see each other. And that's the reason and purpose of having a supervisor in research, especially in emergency medicine. And of course, you have to play your role as a mentee. You may not have the same kind of a level of experience as your supervisors. So we have to work as a team. Even though you think that you are on your own doing your research, it's not true. Actually, a research project or program is actually a team effort. And the primary investigator is always the supervisor, which you rely on his or her credibility as a researcher. Now, this is actually has to be monitored through the activities of research output of the researcher as a project leader. Okay, so in the group or in the team, there are researchers, of course, the primary investigator, then the researchers, which include yourself, and also some associates, which may not be the person that actually do the study, but they help you to actually collect data, for you to analyze your data and so on. So these are associates. So you need to identify the role in the team. And why are you doing this? Because some people give example, I want to sit for final exam. In UKM, doing research is actually a requirement to sit for the final or exit exam of the emergency medicine program. for you to become a specialist. So that could be a reason why you do research. Some people a bit more advanced, they want to have recognition. So recognition is through the publication of their research. And maybe for your supervisors, and for example, for yourself as well, is to get yourself promoted in terms of better pay, better salary, better, you know, for you to progress, to get your, you know, climb up the ladder of academia or your work. So these all things, you know, individual understanding of why you do research. But for me personally, my own reason is basically at this stage of my life, I feel that my contribution is for humanity, is to you know, to leave something before we, you know, leave this earth permanently. So knowledge is always something that we leave behind, and people can use it, especially good knowledge. Okay, so one of the 3 deeds, this is from our from the Islamic tradition, states that one of the 3 deeds that continue to flourish long after when we are gone are, 1, to have good descendants or children, for example, that, you know, continue to pray for us, and donations. Okay, and the last one is knowledge that is useful. So if your publication, people keep on citing and contributing to the good of the humanity, you will actually, inshallah, as we say, will continue to get the good deeds even long after we are gone. So so from my perspective, I think is one of the effort of this program is to convert want to versus need to. So want to is something which is really nice, make things easier, rather than you have to or need to. Okay, so we want to try to convert from need to want to, or to have to. Okay, so how to do research, as we will hear later today from the presentations. We start with a research question, and we use a simple mnemonic for it. And after we have actually start the research question, then we have to proceed with the research proposal and research findings or investigation and data collection. Okay, so please start. For all of you, I hope you all can still read. Literature review is very important, so that we will find the gap in the knowledge, line of knowledge, so that we can contribute and create the research question for that missing information. Okay, with that, I think all the best. I would like to say to all of the presenters today, and all the best to the judges as well. Thank you so much for being with us. So with that, I end my presentation. Thank you.
Thank you, Prof. Having published so many papers, Prof. Khaldun had highlighted the importance of knowledge sharing and the significance of publishing our research. The tips and tricks given will definitely benefit us all. For now, let's start our knowledge sharing session. For the first session, we will have 3 presenters, which are Dr. Elise Wong and Dr. Farah Abdul Latif from UKM, Dr. John Shu Feliciano Ortiz from University of Philippines General Hospital. And now, to briefly introduce the judges will be Dr. Dazli Masdiana Sabadin from UKM and Dr. Ali Haider from University Brawijaya. Gentle reminder to the audience, you may type up your questions in the Q&A box. Please also state who you intend the question to be answered by. To the presenters, please stay still until the end of the Q&A session. Dr. Elise, you may now proceed.
Okay, good morning to all, to the my fellow colleagues and all the judges here. Yeah, today I will be presenting on my my research, which with the topic of effect of COVID-19 pandemic during movement control order on utilization rate of each triage category in the emergency department of my hospital, which is the Hospital Chancellor Tuanku Mukhris HUKM. Okay. All right, so I will start off with my capsule summary. So why is this topic important? It's because the emergency department is served as a frontliner, which plays an important role in actually controlling the spread of the disease during both pandemic and managing non-COVID condition. And what has already known about this topic? So there are a few literature review prior to this, which is the first one is during the SARS pandemic in 2006 by Huan et al. And Chen et al. I will present more on this later, and the trends and effect or pattern of utilization of ED during the COVID-19 pandemic in the US and Portugal, and also the effect of state of emergency restriction in the Australia to ED visits of different triage categories, which was published in 2020. So what question this study wished to address? So the first research question is, what are the effects of movement control order during COVID-19 pandemic on utilization rate of each triage category in our ED of each CTM? And is there any association between the patient's characteristic and the rate of utilization? So how does this study add to our knowledge? It provides insight on pattern and rate of ED utilization of patients in different triage category during the MCO of COVID-19 pandemic. And this knowledge will be relevant to us because this knowledge will help us to prepare to handle the current and future pandemic threats in our ED. Okay, let's move on to our first thing of our research is our abstract. So brief introduction to my research. First is that implementation of lockdown was identified as a factor that affects the utilization of ED globally during COVID-19 pandemic. So my main objective is we aim to compare the ED utilization rate based on different triage acuity during movement control order of COVID-19 pandemic in our teaching university hospital at Hospital Chancellor Tuanku Mukhris. So the method, this was actually a retrospective study which include patients presented to our ED during MCO. This is actually our first MCO, which started on the 18th of March to 9th of June 2020, and a similar period of pre-pandemic period for comparison. So we did a randomized cluster sampling. It was performed based on different triage categories, and we measured outcomes such as demographic, comorbidities, type of cases, mode of arrival, and disposition. So all the data were analyzed using chi-square test. So the results that we got, this distribution of cases based on triage acuity were consistent between MCO and pre-pandemic period, with the lowest triage acuity, which was the triage green, had the highest utilization, followed by second triage acuity, which is a triage yellow, and finally highest triage acuity, which is triage red. For triage green, adult and elderly, married, and presence of comorbidities group were the main presenters and were more likely to require admission during MCO. For triage yellow, which is a semi-critical triage, were higher amongst adult and elderly and married individuals during MCO. Pediatric age group, however, was significantly reduced in both lower triage acuity categories. In terms of ambulance arrival, majority of patients belong to the semi-critical triage, which is the triage yellow acuity categories. Triage red categories, patients did not demonstrate significant changes. So conclusion is, MCO implementation during COVID-19 pandemic did not change the rate of patient presentation based on triage acuity. However, pattern of cases in the lower triage acuity shows some differences. Okay, so I will move on with the introduction. Okay, COVID-19, which we already know, is actually caused by our severe acute respiratory distress syndrome, coronavirus 2, which is a SARS-CoV-2. And it was identified as early as in December 2019 in Wuhan. And after that, it has been spreading rapidly across the globe. So the WHO has actually declared this as a pandemic on March 11, 2020. So Malaysia, which is my country, responded to the COVID-19 pandemic by implementing a first movement control order, which is it can be a state of emergency in other country, or in Malay, we also known as Perintah Kawalan Pergerakan, which started on March 18, 2020. This serves actually as a temporary measures to reorganize, to relocate healthcare resources, and to prevent healthcare workers from burnout. So there are few studies that was published in 2020, and it shows that there was a reduction in the ED patient volume during the pandemic. However, there are actually very few data regarding implementation of lockdown on the acuity of the ED visits. Okay, let's move on to the literature reviews. What does the literature reviews tell us? So United States and Portugal actually reported that emergency visits declined significantly by 42% and 48% respectively during the early COVID-19 pandemic, with the highest decline in the US was seen in children aged less than 15 and also in female population. So according to this article, the possible factors that may affect the utilization of the ED during this pandemic, which include movement restriction, transportation problem, avoiding risk of infection, and moral conscience to actually avoid overloading the healthcare services. So the minority groups that have lack of access to ED, they will be more affected because they seek treatment late. Yeah, due to the risk of infection in ED. So there's one study that was published in Australia stated that the state of emergency restriction in the Victoria City had actually caused a significant decline in ED utilization across all triage categories, except the most urgent triage categories. They think that it's because of when you go to the most urgent triage category means you actually really needed it. It's maybe due to the urgent nature of the disease. So the proposed reason for the under-attendance was due to misinterpretation of the stay-at-home order by the public, and as well as fear in contracting the disease in the ED. So this is my research question. First, what are the effects of MCO during COVID-19 pandemic on utilization rate of each triage category in the emergency department of Hospital Chancellor Tuanku Mukris? And the second research question is there association between patients' characteristic and rate of utilization? So going on to the general objective is to evaluate the ED utilization rate according to triage category of a teaching university hospital in Cheras of our Hospital Chancellor Tuanku Mukris. And our specific objective is to determine the utilization rate of patients with different triage acuity that presented to the ED during MCO of COVID-19 pandemic and compared it with pre-pandemic. Second, to compare the rate of utilization of ED during the MCO of COVID-19 pandemic from the pre-pandemic period. And the third specific objective is to determine the association between patients' characteristic and the rate of different triage acuity utilization. Our hypothesis is the first thing, utilization rate of patients with different triage acuity does not change during MCO. With the ED triage green, still have the highest utilization followed by triage yellow and triage red during MCO similar to pre-pandemic area. And our third hypothesis is that there is an association between patients' characteristic and utilization of ED of different triage acuity. So this is my methodology. My research design is a case control retrospective study using the patient's record. And we have a computer system which have all the patient's record in it. And study location is in our ED. The project period is actually in a period of 1 year from 1st March 2020 to 28th of February 2021. So my study population is that we included all the patients that present to our ED from the 18th March 2019 to 9th of June 2019, which was before the COVID-19 pandemic. And from 18th of March 2020 to 9th June 2020, this is exactly the period of our MCO, the first MCO which was implemented before we move on to the second phase, which is the conditional movement control order. So my inclusion criteria was all the patients that visited ED of HCTM from that period, and we compared in 2019, and we compare it to the period of 2020. Our exclusion criteria is the patients with incomplete data and patients in triage away category. So the sample size, we calculated using single proportion formula based on the data from the medical record of our hospital. So the overall percentage of triage green patients in 2019 was 55.4%, triage rate low was 34.5%, and triage rate was 5.2%. So hence, based on the calculation, the sample size required was 803 samples. And because we want to add on for the incomplete or missing data, so we add on additional of 10% to cover the incomplete and missing data. So therefore, the number of sample size which required for this study was at least 883 before the pandemic and 883 samples during the pandemic. So how we randomize it? From the sample size calculation, we chose 7 days in each month of March 18 to June of 9, 2019, and 7 days during the first MCO period in order to get the required number of samples for each comparative periods of before and during COVID-19 pandemic. The dates were then chosen randomly using computer-generated numbers where they will be representative of all days in a week, including the weekends. So 43 patients were randomly selected from the chosen day using the computer-generated numbers from the list of patients on that particular day, which was arranged based on the time of registration to our computer system. So this is the study flow chart. So we collected all the record logs of all the patients during that presented to our ED from 2019 and 2020 during the MCO period, and then we extracted from the patient record log, and we recorded patients' mode of arrival, presence of comorbid, type of cases, triage category, and disposition. And then we after that, we recorded into Microsoft Excel and coded them, and we analyzed the data using SPSS. So any missing data and a patient which were only seen at triage and we triage away will be in the exclusion criteria. So let's move to our results. Okay, so this is the utilizations according to the triage categories. As you can see, there's not much of a difference in the utilization based on the triage categories. The green still has the highest compared to the yellow, and also red, which is almost similar. And our statistically result shows that it's not significant. So this is the table that I would like to show. And we actually had 871 patients in 2019 and also 880 patients in 2020 with a response rate of at least 96.5% and response rate of 97.5% during the pandemic. Okay, so let's move on to the other result. So this is the utilization rate according to age categories in triage green. As you can see from the less than 14, which the pediatric age group, we can see that there's a significantly lower attendance rate during the pandemic, and is statistically significant. And there are more adults that of middle age and also elderly that goes to the triage green, which is our triage green is the least critical patient. This is a non-critical patient. So followed by the semi-critical, we can see that there's actually significantly reduction in the pediatric age group as well. However, in our most critical zone, which is the triage rate, there's no difference in the attendance. However, you can see the pediatric is still attendance is still slightly lower compared to the adults. Okay, let's move on to the gender in triage, the effect of gender to the utilization rate of the triage categories. In green, there's not much of a difference actually. As compared to the yellow, there's also no significant changes. And in triage rate, there's no significant changes as well. And as to the utilization according to marital status, is you can see in triage green, which is a least critical, there's more married individuals that present to the triage green during the pandemic period. However, in triage yellow as well, there's significantly more married individuals. However, in triage red, there's no significant difference in their attendance. Okay, we analyze the utilization according to presence of comorbidities in different triages. So the first is triage green, which is a non-critical as well. You can see that there's actually more patients with presence of comorbidities that present to the triage green in during the pandemic. However, in triage yellow, there's no significant difference, and in triage red, there's no significant difference as well. Okay, the next one, we analyze the the utilization according to mode of arrival in triage yellow and also triage red. In triage yellow, we can see that the ambulance arrival is actually almost double during the pandemic to triage yellow. As you can see here, it's 7.5% compared to almost 14%. And this is statistically significant. However, in triage rate, there's no significant difference. Okay, the analysis on the type of cases to triage screen, there's no significant difference as well. We actually divide into trauma and non-trauma. And the chi-square test shows that there's no statistical significance.
Sorry, Dr. Wong, you only have 5 minutes left.
Okay, and then in triage yellow, there's no significant difference as well, and triage red, there's no significant difference. And according to disposition in triage green, we can see that there's more patients that actually access and require inpatient care during the pandemic. In triage yellow, there's no statistical difference, and triage red as well. So we move on to the discussion. So utilization of all triage categories actually did not differ significantly during pre-pandemic period and during MCO of COVID-19 pandemic period. So with the triage green still remain the highest, followed by yellow and red. However, utilization of triage green was significantly higher in patients with presence of comorbidities, and they are likely to require admission for inpatient care during MCO or COVID-19 pandemic. So with this finding, we postulated that patients that visited our ED during MCO had higher acuity compared to pre-pandemic period, although they present to the lowest acuity triage category. And also, ambulance arrival was significantly more during MCO or COVID-19 pandemic for yellow zone patients. So the previous study have shown that patients who arrive by ambulance has higher acuity level. So that's why we conclude that patients arriving during MCO most likely have higher triage acuity presentation compared to pre-MCO. Patients with presence of comorbid such as hypertension, chronic lung disease, and those patients who contracted COVID-19, they have poorer outcome compared to patients without comorbidities. So the higher attendance of patients going to our green zone, which is the non-critical zones during MCO, may be due to the fear that this population and they tend to seek treatment early when they are sick. We also find that there was significant reduction of proportion of pediatric age group in both lower acuity patients, which are the triage green and triage yellow. And we share similar result with the Argentina and Canada findings by Ferrero and Goldman et al., which shows that there's a significant reduction in ED visits among children and young people. So among the identified factors were physical distancing with school closure, with reduction in spread of COVID-19, and also parental fear of contracting COVID-19 in the hospital. So however, we found that there was no association between trauma or non-trauma in implementation of MCO during COVID-19 pandemic. However, earlier reports noted a decrease in the number of cases of motor vehicle collision during COVID-19 pandemic. So our limitation of study is that this study was conducted in our ED of a teaching university hospital and may not be representative of other hospitals in Malaysia. Second, there's lack of reporting regarding arrival through other ambulance services. We only took the ambulance arrival through our ambulance and the retrospective design of this disease. So for the future continuation of this research, it can be done to look at a total number of cases during the pre-pandemic and during MCO period with diagnosis of patient included so that we could assess whether the ED patient case mix would have changed during MCO. So our conclusion is implementation of MCO during COVID-19 pandemic has certain effects to the pattern of utilization on triage categories in the ED, mainly the lower acuity. Although the exact reason for these changes were unknown, it is crucial for physicians and public health to emphasize on the importance of seeking medical treatment for urgent medical problems during MCO or COVID-19 pandemic. Okay, with that, thank you.
Thank you, Dr. Wong. Up next, Dr. Farah, the floor is yours.
Okay, Assalamualaikum. Very good morning. Salam sejahtera. Thank you, Chair Lady, Dr. Evelyn. I think, can you see my slide and can you hear me well?
Yes, clear.
All right. Okay, very good morning to the panelists and everyone. So today I'm going to talk about my thesis. So this is a preliminary study, awareness and knowledge level of cardiopulmonary resuscitation among hearing impaired secondary school students. So this is the abstract. Background of the study: cardiac arrest is still a major health issue and contributed to most of the non-communicable disease. And cardiopulmonary resuscitation is a potential life-saving skill that should be taught to everyone, including the disabled community, such as the hearing impaired person. However, limited facility available for the training and training of the basic life support for the hearing impaired population, and it needs to be addressed. This was a cross-sectional research with collection of data of 50 samples, and the data collection was carried out in Sekolah Ampuan Durrah Negeri Sembilan and Vocational Special Education Secondary School Shah Alam, Selangor. Video edit questionnaire was distributed using Google Form application by designated teacher from each school to the students. So 50 Google Form were collected from 50 secondary school students from Sekolah Ampuan Durrah Negeri Sembilan and Vocational Special Education Secondary School Shah Alam. From the data collected, only about 32% has seen a collapse victim. More than half of them, about 65%, has witnessed a CPR done, and 66% of the students have learned about CPR before this, and 80% of them claim that CPR has been taught in school. 88% of the students recognize the act of chest compression and think that CPR can be done by layperson. However, only 24% has seen an automated external defibrillator, that is the AED. There were 18 students with total knowledge score of less than 60%, which was score between 0 to 7, and 32 students with a score of 60% to 79%, which was score of 8 to 10 out of 13. So none achieved total score of 11 to 13, which is the high level of knowledge. There was no demographic association in the level of awareness nor in the level of knowledge of CPR in the hearing impaired student, secondary student. So the conclusion was the level of awareness of CPR is still in the moderate level and need improvement. There is a lot to be done to improve the CPR knowledge in the hearing impaired secondary school student population, and a proper development of basic life support for the hearing impaired population should be initiated. So I'll go through the capsule summary. So why this topic is important? This is important because out of hospital, cardiac arrest can happen anywhere to anyone. Therefore, everyone, including the hearing impaired, should have the knowledge and skill to do CPR and early defibrillation. So what is already known on this topic? Well, we know that cardiac arrest is still a major health issue, and outcome of out-of-hospital cardiac arrest and survival rate relies strongly on timely cardiopulmonary resuscitation, that is CPR, and defibrillation then. So Disability Act 2018 stated that the disabled population should not be discriminated in getting access to health, education, employment, information, and communication. So what question this study wish to address? So we want to determine the level of awareness of CPR, to determine the level of knowledge of CPR, and to determine demographic association and the level of awareness and knowledge of CPR. What will this study add to our knowledge? That is to understand the level of awareness and knowledge of CPR among hearing impaired secondary school in Malaysia, and to understand better the best way in gathering information from the hearing impaired population. So how will this knowledge be relevant to clinical practice? That is to gather information on limitation of the current study for development of better future study in the future, and to guide for proper development of basic life support course for the hearing impaired population. So these are my literature review. So according to WHO 2018, in 2016, 71% of deaths are from non-communicable disease, and cardiovascular disease contributed about 47%. In Asian countries, layperson CPR rates was reported around 18.5% to 40.9% only. And the provision of early CPR for out-of-hospital cardiac arrest by the public in the Cheras area is low. Cheras is in KL, and AED was not widely available for public use. So immediate bystander CPR with early defibrillation has been proven to double the survival rate in out-of-hospital cardiac arrest. And out-of-hospital cardiac arrest happen mostly at home on residents, which make up to about 69.5%, while 18.8% in public setting and 37% are witnessed by layperson. And not to forget about the Disability Act 2018 in Malaysia, which consists of number 1, accessibility to the physical, social, economic, and cultural environment. Number 2, accessibility to health, education, employment, information, and communication. And number 3, equal opportunities, protection, and assistance in all circumstances and subject only to such limitations, restriction, and protection of rights as provided by the Federal Constitution of Malaysia 1957. So my research justification, basic life support is a life-saving skill that should be mastered by everyone in the community, and out-of-hospital cardiac arrest can happen anywhere, anytime. Early CPR and prompt use of AED will determine the prognosis of the victim. Disabled communities should be able to get access to health facility, training, and information. My research question is, what are the level of awareness and knowledge of cardiopulmonary resuscitation among the hearing impaired secondary school students? So the general objective of this study is the aim is to determine the level of awareness and knowledge of cardiopulmonary resuscitation among the hearing impaired secondary school children. And the specific objectives are to determine the level of awareness of cardiopulmonary resuscitation among hearing impaired secondary school students, to determine the level of knowledge of CPR among hearing impaired secondary school students, and to determine the association between the demographic profile with awareness and knowledge of CPR among hearing impaired secondary school students. So the hypotheses are the level of CPR awareness among hearing impaired population is normal, and the level of CPR knowledge among hearing impaired population is normal, and there are significant association between demographic profile with the awareness and knowledge of CPR. So the methodology of this study, the study site were in Sekolah Ampuan Durrah Negeri Sembilan and also Vocational Special Education Secondary School Shah Alam in Selangor. So study duration was 12 months. Study design, it was a video aided questionnaire in Google Form application, and it's a cross-sectional study. So inclusion criteria, all level of hearing impairment, including the students in Form 3, Form 4, and Form 5. And exclusion criteria were intellectual disability and physical disability. So this is the example of the video aided questionnaire. So moving on, my study should have at least 100 participants, but however, due to COVID-19, we have to change this study into a preliminary study as schools were closed and it was difficult to reach out to the students. Most students came from middle to low income family, therefore most of them do not own a mobile phone or tablet and had difficulty to access to the internet. So we had to combine, actually Sekolah Ampuan Durrah Negeri Sembilan was my pilot participants, and the Special Education Vocational School Shah Alam was the one that supposed to be the real studies lah. But I have to combine both of them and make it into preliminary study. So this is my study flow chart. Research conducted after approval from the ethical committee, and then submission and approval from the Ministry of Education of Malaysia and approval from the school principal. Then the questionnaire distributed and collected, and data analysis and interpretation was done. So the results, demographic data, total number of students included were 50. So there were 3 from Form 3, 13 from 4, and 34 from Form 5. Race, Malay most, according to the population. So 35, Chinese 13, and Indian only 2. Deafness unilateral were 18, and bilateral 32. And mother's education level, not schooling, only 2, primary school 5, Form 3 7, SPM 30, diploma 2, and degree 4 of them. So father's education level, not schooling about 2, primary school 7, Form 3 11, SPM 21%, diploma 5, and tertiary 4. So time deafness occurred before birth, only 13 participants, and after birth 37. So these were the descriptive analysis. CPR awareness questionnaire. So question 1 were on witness victim collapse. So about 32% say yes and 68% say no. Recognize the act of chest compression, 88% say yes. Witness CPR done before, 56% say yes, and learn about CPR before, 66% say yes. and where they actually seen a CPR done. So 76% said in television, 60% in books, and 68% in internet. So were any CPR taught in school? So 80% of them said yes. CPR can be done by laymen. They agree. 84% of them agree that it can be done by laymen. And have they seen an automated external defibrillator or AED? Only 24% said yes. So the level of knowledge, according to the Bloom's cut-off point, so we divide into low, moderate, and high. So according to this, about 36% of them had low knowledge of CPR, 64% had moderate knowledge of CPR, and none had high knowledge of CPR. So this is the association between the demographic and also awareness and knowledge. As we can see, P of less than 0.05 is statistically significant, but none of them are statistically significant. So there's no association of demographic between awareness and knowledge. So discussion CPR awareness, more than half of the participants have come across the topic of CPR either in book, seen it on television, or read about it in the internet. And more than 80% of them recognize the act of chest compression, which is the most important part in cardiopulmonary resuscitation. However, about 76% of them have never seen an automated external defibrillator before, and previous study done by Strand and Salda showed that it is challenging for a deaf person to use an AED, as most of the machine use voice prompt. So good CPR awareness, but low AED usage awareness. On CPR knowledge, it is not surprising that the level of CPR knowledge is at low to moderate. And basic life support is not compulsory in Malaysia curricula, and students can learn it when they enroll into the Malaysian Red Crescent Society as their extracurricular activity. So there's no actually proper or formal teaching on basic life support in our Malaysian curricula. So demographic association, participants are school children who are taught with the same unified formal sign language of Kod Tangan Bahasa Melayu, that is the sign language in school. And most of them also use Bahasa Isyarat Malaysia, BIM, as their daily communication tool. And language is important and critical to the organization of memory and mastering cognitive skills. Early intervention in the development of language is critical, even if it is sign language from birth, but most are often not detected before 30 months of age. Mild hearing loss range would be around 16 to 25 decibels, and profound hearing loss would be above 91 decibels. But in this study, we did not actually gather what are the level of the hearing loss. Therefore, it is hard to categorize unilateral and bilateral hearing loss into either slight, mild, moderate, severe, or profound. Unilateral deafness has shown to affect adequate speech development as well as the bilateral deafness. So demographic association, again, studies done shown that parental communication skills plays more significant role in the student's performance compared to parental involvement in education. And through this study, parental education's level is not significant in determining the student's level of CPR knowledge. So the research limitation were limited number of the data collected and limited studies available on CPR and hearing impact population, therefore difficult to make comparison. So recommendation of this study, full-scale data collection should be carried out in the future, I hope, inshallah. The questionnaire need to be revised with more specific questions to clarify certain issue in depth. For example, explore the type of training taken when learning CPR, either formal or informal. This data will also be the platform of the subsequent study to be carried out to raise awareness and give CPR trainings to the speech and hearing impact population in Malaysia. So to train basic life support to more teachers who are able to sign in order to assist with the study. And this will give them better understanding on the topic of CPR. A policy making to make it compulsory to place an AED in schools and more public places such as recreational center, public transport places, and universities. So the conclusion of this research, the CPR awareness among the hearing impact secondary school children is satisfactory, and most of them have encountered CPR in either their reading in book or the internet or have watched it on television. and majority of them were also aware of the act of chest compression. However, more initiative needed to introduce AED to the hearing impaired population. Production of visual prompt AED is needed in order to assist the hearing impaired, as they cannot rely on the voice prompt AED. And we accept the hypothesis that the level of CPR in the hearing impaired population is normal. The knowledge of CPR among the hearing impaired secondary school students are still at moderate to low, and basic life support is not a compulsory subject in school. More work needed to bring basic life support into Malaysian education system. At the same time, development of basic life support course to cater for the disabled, such as the hearing impaired, should be initiated.
Sorry, Dr. Farah, you only have 5 minutes left.
Sure. There is no demographic association with the level of awareness of the level or the level of knowledge, and this study as a stepping stone on understanding the limitation on developing basic life support course to the hearing impaired population. With that, thank you.
Next up, Dr. Somera, the floor is yours. Dr. Somera will have the pre-recorded video presentation. Thank you.
Have you ever been rejected? Imagine a shift wherein you've been decked with a very sick patient. You have done your best and stabilized them, and you are ready to endorse to the inpatient physician. But you saw that the one next on deck was someone who was a bit more senior than you and was tagged as one of those difficult people to endorse to. But just when you were about to call, you saw the triage officer coming in with another patient. You realized that the ED is starting to get crowded. There is now this added pressure to you. However, at the end of your conversation with the inpatient physician, this is what you were told. Or perhaps this, or maybe even this. Now, in the course of all the conversation you had, the patient went from very sick to critical, then to an eventual mortality. As an ER doctor, I have experienced rejection more than the hours that is in my shift. And this is a usual scenario at our emergency department. Our interaction with the inpatient physicians as we admit patients from the emergency department are not always smooth, but it is necessary. The dialogues you see are some of the lines that we are all familiar with. And just like in any other relationship, communication has a vital role in how we transmit information. This method of conveying vital clinical information and transferring the responsibility of care is what we know as the handoff process, or commonly known as handovers or referrals. Many information can be lost in translation amidst the chaos that is in the emergency room. Failure to convey vital information has contributed to events that risk the patient's safety, delays the management, and increase ED overcrowding. In our hospital, we have not fully evaluated how this handoff process works, and inter-unit handoffs remain to be a neglected area, which has led to this study on exploring the inter-unit handoff from the emergency department to inpatient care at the Philippine General Hospital. According to the Joint Commissions International, 80% of serious medical errors involve miscommunication between caregivers when patients are transferred or handed off. In the 2018 Philippine Health System Review of the WHO, improvement of communication was identified as an important concern, but the culture of health workers towards handover remains undetermined. Hence, we wanted to find out what are the current practices of handoff already present in our ED, and what are the possible barriers in communication that contributes to failure. We also wanted to find out what are the factors involved in the inter-unit handoff process at the emergency department. To answer these questions, we have done a single-center descriptive cross-sectional study within a 6-month duration at the emergency department of the Philippine General Hospital, which is a tertiary training hospital that receives a number of handovers. The tool used was tested and validated, and a 42-item Likert scale questionnaire was distributed via Google Forms to the target population, which were residents that had experienced handoff interaction at the emergency department. The data collected was analyzed through descriptive analysis and inferential statistics with the use of factor analysis. The tool that we used was divided into subgroup of questions with our theorized factors. The factor analysis worked by extracting commonality between different variables in the questionnaire and put them under the same heading or a factor. From the different items, we have identified 3 factors. The first is the organization context. The handoff process is built in a complex framework that is layered and affected by cultural aspects such as hierarchies, trainings, and existing policies. We asked the question, does hierarchy affect the handoff process? And 55% from the 223 respondents affirmed that. Studies have shown that junior trainees who were observed in handover to a more senior resident had difficulty and most were intimidated. This kind of response can also be attributed to the training and feedback they have received in handover. 31% of the residents said that they did not have any formal training in handoff, which tells us that insufficient level of training undermines the competency of these residents in giving and receiving handoff. When asked if a standardized tool would help improve the handoff process, 70% responded affirmatively. A study has shown that implementation of a handoff tool shows significant reduction of errors, making it an important game changer. All these are intertwined with the next factor, the negotiation context. This is where we ask questions pertaining to the interpersonal aspects of the discourse. As emergency physician, we have mastered the art of persuasion and at times resort to bargaining just so we can have a patient admitted. One particular aspect that we found important is the attitude of clinicians. Going back to our earlier illustration, when you are faced with someone who already have an aggressive attitude, there is added pressure which affects the handover. Another important aspect of negotiation is omission. 35% of the respondents said that almost always important information are being omitted, which may be due to the intention of packaging the patient in such a way that will favor admission. In our study, here are the top 2 information that are always being omitted. And it can be due to the fast-paced environment at the ED, and maybe also because the residents themselves lack the awareness that these are important information that need to be transmitted. Lastly, there is handoff interaction, which involved items pertaining to information transfer. The idea of information transfer is similar to a baton relay race, wherein you hand over the baton to the next player, in this case from the ED physician to the inpatient physician. You can't pass half a baton or throw it to the next player haphazardly because the continuity of care of the patient rely primarily on the vital information that we hand off to the next physician. In our study, we have identified the top 10 important information that should be included in handoff interaction. The items listed can be related to items pertaining to the management of the patient and the clarifications necessary to transfer patient care effectively and safely. This information are essential because an irrelevant or incomplete detail may be detrimental to the patient. To further analyze the tool, we did an exploratory factor analysis. The theorized number of factors were initially 3. The scree plot shows the different factors that are above the eigenvalue of 1. As you can see, 5 nodes are present above the line, which means that there must be 5 underlying factors in the questionnaire. The components that were identified are as follows. The first 3 are those that were initially theorized, and the additional 2 factors were related to items in the questionnaire pertaining to information on the management and treatment of patient and the proficiency of residents in receiving and giving handoff. These factors has shown significant correlation with the other factors but still needs further investigation. In conclusion, communication would always be an integral part of the healthcare system. In the emergency department, wherein communication happens amidst critical cases, the transfer of essential information becomes an anchor for patient safety. Therefore, it is important that gaps in these transitions are properly assessed and factors affecting the multi-layered framework of the handoff process be identified and addressed accordingly. The tool used was able to identify factors which are involved in the handoff process, and we have seen that hierarchy, the clinician's attitude, and the lack of formal training in handoffs affect the process and are possible barriers which contributes to failures in communication. In the current status of the handoff from ED to inpatient, there are vital information that are not conveyed due to omission, and residents themselves have identified there is a need for standardization in order to facilitate a better handover that ensures safety of patient transfer. Imagine a shift where instead of misunderstandings, turf wars, and dread of rejection, there is shared understanding, collaboration, and acceptance. That is going to be what every shift is like if we improve our handoff. Thank you.
Thank you, Dr. Marianne. A very interesting and unique presentation you have here. Now we will have Q&A session. Dear judges, dear judges and all of you here, you can now share your opinion.
Hello, Dr. Wong. Congratulations for your good presentation. Okay, my question is that during this MCO, of course, there are some adjustment to the system, especially for our emergency department, right? And some can be mentioned like you have to do the screening, the triaging, as well as the cohorting. And even some of the hospital activates their hospital disaster plan. As I believe that we also do the screening for all of our patients. And so how would this affect your research regarding triage and categorization and utilization? Thank you.
Okay, because that time when the COVID-19 pandemic hit, it was actually quite a chaos in our ED, and there are a lot of changes to our ED. We did segregate our ED into the respiratory and non-respiratory zone, especially our yellow and our green and also red. So because there are a lot of times that the patients sometimes are wrongly triaged into the wrong, like let's say the patient has a fever, and then in triage they didn't detect it, and then when they landed in our non-respi zone, so after that we have to transfer back the patient to the respi zone. So when they actually put the thing into our system, whether it's a respi or non-respi, it's sometimes it's wrongly coded. So that's why when we look retrospectively, it's very hard for us to determine exactly is this patient a respi or a non-respiratory zone. So that's why at the end of the day, when after much discussion with my supervisor, and also we decided we just segregate into yellow, and we didn't yellow and red and green. So we didn't actually look at the case mix of the patients. So in future research, if we have more time, definitely we can actually look back at the all the documentations and all, and then we can actually decide what kind of case are that, and then probably that time that we can do a future research on that. Yeah.
Okay, Dr. Wong.
Yes.
Right. So I believe your study is regarding the first MCO.
Yep.
So how would your findings will actually affect the future management, or how you want to allocate the ED resources, because now COVID-19 surely will be endemic in most of the countries. So what do you think?
Okay. So like let's say, for example, for what I found that is that we found that, like, let's say in patient in triage yellow, they have higher ambulance arrival during the pandemic. So if we can actually, if we manage to, let's say, look at all the cases and all, probably we could actually allocate more ambulance to that, to yellow, I mean more ambulance services, because they utilize more of ambulance in yellow zone. And yellow zone actually has the most patient in our ED compared to the red zone and also green zone during the pandemic. And then second thing that is what we found is that the pediatric cases has significantly reduced during the MCO of a COVID-19 pandemic. So probably with that, we can actually channel more resources. Like let's say, for example, we can actually use most of the pediatric wards, and we allocate it to the, we open up more wards for the other adults and all.
But for the current trend, most of the adults are already being vaccinated. So I believe that most of the adults infected with COVID are usually presented with Cat 1 and Cat 2, so they're rarely being admitted. So the concern is now towards the pediatric and also the maternal age group. So what do you think?
Yeah, so I think we need to do another research and we look at the current trend, because this research was done in early pandemic, which is in the first MCO, where the pandemic just began. But now, because I think the trend might have changed, because everyone is being vaccinated and all that. And as we can see, when we observe generally in our ED, there are still some of them, the PIDS cases that came in with very bad lungs and all that. So therefore, I think we need another research, the continuation of research, and see the trends and in current in 2021, because what I did was much earlier.
Thank you, Dr. Wong. Do you have any questions, Dr. Ali? Or we can ask other questions to the other presenters. I want to ask Dr. Farah. Sorry, just now I missed out regarding the questionnaire. So is the questionnaire you build it yourself, or is it adapted from other studies?
So the questionnaire was actually adapted from Dr. Hisham's studies, the one that they went to Aceh and did the FIT CPR. So it was adapted from there, but we cannot use it as it is because the questionnaire was actually complex for the hard on hearing students. So it's really hard for them to actually understand. We actually did a trial of giving the questionnaire in a tournament for the OKU or disabled people. So we actually give out the questionnaire, ask them to fill it out, but they find it hard to actually understand the question. So the teacher had to actually sign language the question to them for them to answer. So that's why we come up with the video edit questionnaire, but it was simplified because sign language is not like the normal language. They do not have grammar. They do not have like the and, before, when, or they just, let's say if you want to go to the toilet, toilet, that's all. That's the sign language. That's why we cannot actually use the original sign language with the proper grammar and everything.
Okay, so I just quite interested with the video that you've actually used for the questionnaire. So the person who did the sign language is a teacher, is it?
The person who did the sign language is a student taking a degree in UKM Bani, University Kebangsaan Malaysia Bani. So she's actually a mainstream student who actually took SPM and then entered special education program in University Kebangsaan Malaysia. So she's actually a hard on hearing student as well. So that's how we actually get her to actually sign for us.
Okay. So one of your suggestion is actually to include the CPR teaching in the school curricula. So I think if it's in normal students, is quite straightforward because it's more of your skills and also you have to practice and more of visual aid, visual, and also you have to conduct the course as it is. But if in a hearing impact students, so how would you modify the CPR teaching lessons. Do you understand the question? Okay.
Yes, actually from this study, we learn a lot about the hearing impact population. So it's not just about the knowledge and the awareness, it's about how we communicate with them and how we actually give the knowledge to them. It's not easy, especially when we on our side, we do not know how to sign. And for them, it's they can't hear us. So it's actually two things. So we need educator who can actually sign. So we need to actually teach more teachers who can sign on CPR so that they can assist us on teaching the CPR to them. So it actually an eye-opening doing this study. So it's not just about having the data and everything, but it's actually about understanding them and how we should actually able to communicate and give them the education that they need.
Okay, thank you, Dr. Farah.
Thank you very much.
Do you want to ask any question, Dr. Ali?
All right, thank you. Dr. Farah, congratulations for your great initiation for the disabled population. As you mentioned on your presentation that CPR is a potential life-saving skill, and I believe that it means it is not only knowledge that is important. So how you incorporate this into your research and your future research?
So basically, I just ask your question because I can't actually hear. My internet here is quite bad. So are you saying that how do I actually do this research in future in this kind of population? Is that true?
Yeah, I put on the note in the chat box there. Yeah, in order for you to understand my question. In the chat, yes, please.
So the question from Dr. Ali Haider to Dr. Farah is that, as you mentioned on your presentation, CPR is a potential life-saving skill. I believe that it means it is not only knowledge that is important. So how you incorporate this into your research or your future research? Thank you.
So it's not just the knowledge. When you say it's not just the knowledge, it's not just the knowledge of CPR. It's not just the knowledge of what we want from them or what we want them to know, but it's also the knowledge of understanding a population as a whole. So we need to do more research on that as well. Basically integrating this research with other department or other specialty is actually quite important. So to me, in this research itself, we actually had help from the special education professor in UKM Bangi. So he actually get some help for us to get in touch with teachers who can actually sign and actually verify the video so that it can be understood well by the hard on hearing population. So I guess in the future, I think we need more people of their specialty to actually integrate with us and then make it happen or make it better. Yep.
Yeah, thank you for your answer. And how about the skill? Would you find any difficulties, any challenges in performing the skills to them, in teaching the skill for them?
Okay, regarding the skills, we in this research, we actually have come out with books for the hard on hearing, and we actually have a simplified video of CPR for the hard of hearing using a sign language. So, but it's a very simplified one. So it's just for a lay person to actually just do the hand compression without the breathing side. So it's just a chest compression And then I think if we want to do it in mass, I think the video would be very helpful because it's a video aided, so you don't need to have the audio. But then in terms of them doing the skill, there's no other issue because they are not physically disabled. They only cannot hear. So it's the means of communication with them that is important. But otherwise, when we did the questionnaire study, we also asked them to actually perform, but with the help of their teacher to actually sign for them. So they can actually do it, no problem at all. It's just that the means of communication.
Okay, so there's no important challenges that you encounter with to teach the skill, right? Okay, thank you.
Yes. Yes, thank you.
So now, is there any other question from the judges to the presenter, Dr. Farah? If not, we move on to Dr. Mary Ann. Is there any question for her?
I think Dr. Ali had already put in the chat box.
No, actually, that's for Dr. Farah. Thank you, thank you.
Okay, from the chat box, there's a question to Dr. Mary Ann. From your study, where should the handover better done? Does bedside passover here have any role?
Okay, so based from our study, actually, this was one of the questions that was initially part of our pilot questionnaire. However, it didn't yield any significant result, so we actually edited out on our final questionnaire. However, what we found out was that most of the residents have an equal, they have an equal affiliation to either the bedside or the through phone, especially now because of the pandemic. So it's not much of how or what vector to use in order to communicate, but the information that you actually transfer that's important to them. So it doesn't really matter whether it was bedside or it was over through phone. What we found out that was important is like what I've discussed a while ago, is that the attitude of the person that's giving the handover and receiving the handover, and also the information that's essential to be transferred through that phone call, whether beds or whether in bedside. That's it. So I think it doesn't really matter where it happens. What is important is the information that you actually transfer to the receiving physician. Thank you.
Okay, thank you. To all the participants here, do you have any question for the presenters?
Dr. Marianne, so from your previous experience, so what are the usual problems that usually happens during your Passover?
Like what I've discussed in my presentation a while ago, most of the time our main problem is that because of overcrowding, because there's a lot of patient coming in, so and there's a limited number of resources and even the staff, so sometimes there's a delay in patient admission to from the emergency room to the inpatient or to the wards because of that. And most of our encounters is that some of, like what I've given as an example, is that some of the residents from the other departments, they would say that there's gonna be a discussion, and like it's not our patient, or this is not, I don't think this is the case, like, so there's a lot of arguments that build up alongside it. And one of the sad things that happens is that it becomes detrimental to the patient because the management is also gets delayed. Some of the things that needs to be done to the patient, especially for patients that needs subspecialty services, so some of those things gets delayed because of some miscommunication between the residents or between each department that is involved with the management of the case of the patient. So That's one of the challenges. And also, as I've mentioned, I think one of the barriers is also the lack of the standardized tools, the lack of the standardized tool right now. So I think it's important that we have this tool to use in order to, or at least a checklist that we can use in order to see if the information that we're actually giving to each other as physicians is actually adequate enough for the patient, for the safety of the patient, and also for our own learning for the management of this case. So I believe that, a collaborative approach is the best way to manage a patient and to, in order to help ensure the safety and the welfare of the patient, as well as the learning between the different departments in the emergency room. Thank you.
Okay, so the study is more of interdepartmental handover. So what about, I'm not sure about the system in your ED, but you have to also pass over with your colleagues intershift, right? So do you have any problems or during the handovers?
Yes, I think there are some problems also. We also encounter problems within from another ED physician to let's say to the next shift. But mostly those are just some we only encounter minor issues with regards to, like, for example, laboratory workups that sometimes you forget to endorse it to the incoming shift. However, it's not it doesn't really, it's not the same as with the other departments, because sometimes because our interaction in our fellow emergency room physicians is more collaborative in a sense. But when it comes to other departments, sometimes there's how do you call that, there's a rift, or there's sometimes there's just friction between, because you have two different perspective when it comes of in terms of patient management. So that's where the difficulty comes. So that's why we wanted to have this tool. And I think as you've suggested, since my study is limited to just the interdepartmental and not really from shift to shift, so I think that's one recommendation that we can have for this, that we can also study more on the handovers that happens between one emergency physician shift to another's. So thank you for that question.
Okay, thank you, Dr. Marian.
Okay, thank you for all the questions. Once again, for all the participants, is there any question from you?
Has my question to Dr. Wong been asked in the chat? Basically, my question is, does the trauma patient visit in your study reduce more compared to medical cases other than the COVID related? And if so, what could be the reasons, and could there be anything that we can take an advantage from by redirection of these trauma cases and learn from in terms of future management of safety?
Okay, the trauma from my analysis in all three triage categories, there's actually no significant difference. Just that we can see that the trauma cases, although the cases look like it's slightly lower during MCO, but it's actually there's no significant difference in the number of cases. However, the trauma cases that I include in is not actually purely motor vehicle accident. I also included those that had a trauma at home. Yeah. So I think in future we can actually try to segregate them, whether it's motor vehicle collision or it's other kind of trauma. Yeah. But with the MCO, of course, there's a lot of movement restrictions. So we would actually be expecting less of a trauma cases in our ED.
Yeah, my take is that because of the shift of, for example, number of trauma from motor vehicle to maybe home-based accidents and trauma, maybe there's something that we can do in the future in terms of safety.
Yeah.
Because at the moment, there's nothing come out from the government to really address the issue of safety at home while doing the MCO. For ourselves, our case, for example, is snake bites. We thought that people will not get snake bite, but apparently people get more snake bite when they are staying at home because they start to clean the house and so on, and they get encounter with the snakes. That's an example. So which we only identify during when we do a study about this. Yeah, so that's just kind of interesting. I think that's where, I mean, your research can actually change some policy. You can recommend some policies to the powers that be in terms of safety. Yeah, that's all. Thanks.
Thank you.
Thank you, Dr. Elise. Your research has given a very good opening for future research and maybe policy changing, especially when COVID is the hit topic right now. Is there any other question from the participants or judges or any other panelists from the webinar? If there is none, thank you everyone. So we will now take a short break and make yourself. Oh, okay, sorry, Dr. Ali. Yeah, you may proceed.
Okay, no problem. Okay, my question is actually for Dr. Marianne. Congratulations, Dr. Marianne, for your interesting slide of yours. And okay, on my perspective, there is also relationship between the co-workers and team workers attitude. And how would you identify this as influencing communication in handover process?
I think one factor, like based from my experience, since actually my research is more, like as I said, is interdepartmental. I think based on my experience, one factor that is important is the relationship between the senior residents and the junior residents, because of course, like what we found out, hierarchy is one of the key barriers in terms of handover. So I think like what you've said, relationships between between colleagues are also important. So I think it's important to establish a good rapport with your junior residents or with your senior residents, and also to have that sort of teaching attitude, that people that as a trainee, you should always be teachable. You should always be ready to accept correction, to also admit your mistakes, because I think that's one of the, especially for us as doctors, we're, you know, some of us, we have our own pride and our own issues. So it's very easy to always assume the worst in a person. And I think that's as a team approach in terms of managing a patient, is very important to first establish that kind of good relationship with your colleagues, and as well as the other people who you are working with, not just the doctors, but also the nurses, those people that are in the hospital. So I think, yes, I believe that it does have a very important effect on the handover, because the attitude that you have towards your colleagues also is sometimes the attitude you reflect to your patients. So I believe that it is an important factor in terms of this handover, because the information that you transfer is also affected by sometimes with the attitude that you already have beforehand. Thank you, Ali, for that question.
Okay, thank you, Dr. Marianne. So now we will take a short break. We will come back at 10:10 Malaysian time and Philippine time, and 9:10 Indonesian time. I'll see you guys later. Thank you.
Thanks for coming back. We're back for the second session today. And for the second session, we will have three presenters as well. Number one, Dr. JB Yee from UKM. Number two is will be Dr. Joy Regina Lactupo from the University of the Philippines, Philippine General Hospital. And number three, we have Dr. Muhammad Nakib, also from UKM. For this session, there will be two individuals adjudicating as well. First, we have Dr. Patrick Joseph Tiglau from who is the Secretary General Chairperson in the Philippine College at the Philippine College of Emergency Medicine Research Committee. He's the chairperson of the research committee, and also he's a consultant in University of Philippines, Philippine General Hospital. Dr. Hashim Mbong is a clinical lecturer and emergency physician consultant in UKM, and he takes a special interest in pediatrics and geriatric emergencies. So before we go to the presenters, I would like to give a gentle reminder to the audience. You may type out your questions in the Q&A box, okay, that we have prepared for you. You can type out your questions there as the presenters are speaking. And we will field your questions to the presenters after all three of them have finished during the Q&A session. Okay, and the judges also, we would like to request you to turn on your camera towards the end of the presentation so that we can spotlight you on our Facebook transmission. Okay, so let's get to the presentations. First up, we have Dr. JB Yee. Please take the floor. Thank you.
Hi, good morning, everyone. Thank you so much. Really privileged to be invited for this seminar. So without further ado, I will start sharing my slides. Okay, so is that clear?
Yeah, we can hear you.
All right. So my thesis, my dissertation was about this topic: a qualitative study of the emergency healthcare frontliners, or what we call EHF, perception towards COVID SELS simulation training in resuscitating suspected COVID-19 patients. So a little bit of introduction, and I have included the pandemic timeline here for your reference. Global pandemic timeline. So since the March 2020, WHO has declared COVID-19 as a worldwide pandemic. And starting from the 31st it all started when at the end of the December until 3rd January, they noticed the sudden surge of cases, which is about 44. Pneumonia cases of unknown etiology reported to WHO that time. And they started noticing also in February 11, more than 70,000 cases were reported in China, among which 1,700 was confirmed to be among the healthcare workers alone, which resulting to 5 deaths among the healthcare workers. So Wang Di et al. Noticed that a quarter of the healthcare workers contracted the coronavirus from just a single patient. So from this, we know that it is a very contagious thing. So moving on the 8th of April, WHO also concluded that, also reported that 22,000 of the healthcare workers have contracted COVID-19, and that was in last year. I'm very sure by now the numbers have already been increased. And subsequently, in 25th of April, as predicted, the cases globally has already increased, which is about 2 million, among which Southeast Asia has already contributed like 41,000 of cases now. So a little bit of introduction. Since April 2020, Ministry of Health Malaysia has recorded about 5,600 positive cases, and our health director, Dr. Noor Hisham Abdullah, has in his press meeting mentioned that Malaysia has 325 healthcare workers who has tested positive for COVID-19 and 3 deaths, which among the 325, 77 of them are medical officers, 66 of them are nurses, 34 of them are graduated medical officers, 23 specialists, 21 assistant medical officers, and so on. So National Hospital Infection Management and Quality Control Center in China, one of the reasons for the high number of the infected healthcare worker during the emergency breakout is because of inadequate training for the infection prevention and also control for the respiratory-borne infectious disease. And also they mentioned that when the emergency response was initiated, healthcare workers did not have enough time for their systemic training and also practice in order to prepare them for this pandemic, in order to prepare them for this infectious disease. So they mentioned that professional supervision, guidance, and also monitoring mechanisms were lacking. So from my study, from this study, that actually what we would like to learn is because that we wanted to develop our own COVID SES simulation training and also to train our staff. But we wanted to know their experience after going through that simulation training. So problem statement for my study is that the super spreader phenomenon, which poses a very high risk for our emergency healthcare frontliner, the resuscitation procedure in emergency using standard ACLS guideline is involving the aerosol generating procedure AGP, and also the not to forget the concerns and anxiety arise among the EHF in resuscitating a possible COVID-19 patient. So this is my literature review about the super spreader phenomenon. There are a few that have addresses how infectious and how infectious that the disease can be. Then about SCS adaptation in COVID-19 pandemic setting, not much, but there is where by Dana Adelson 2020, where they mentioned about the latest SCS resuscitation did not address the challenges of providing resuscitation in the setting of global pandemic. Then Lucky Reddy 2020 also, they also further confirmed that the administration of CPR according to SCLS does involve the performing AGP, which include chest compression, positive pressure ventilation, and also establishment of advanced airway. All of these are contributing to, all of these are actually AGP and which contribute possess a risk of contracting the disease for the healthcare worker. Okay, so not to forget the anxiety among healthcare worker in resuscitating a suspected COVID patient. Wu et al. In 2009, in their study was talking about the human swine flu. So they said a large scale of infectious public health event could result in medical staff under both physical and psychological pressure. Tan et al. In 2020, in his study, he said 14.5% of the healthcare workers handling COVID-19 are screened positive for the anxiety. Okay, so my research justification, there's still little knowledge of known regarding this rapid spreading infection. So healthcare frontliner safety should be prioritized. Number two is to create awareness of self-protection among the healthcare worker during resuscitation and AGP. Trainees will be interviewed in regards to their anxiety, aspects of confidence, any benefits from the training and their expectations of other training. And number four is we hope that, we wanted to conduct this study is because we wanted this study to serve as a framework in preparing for future pandemics. So the questions that we are interested in this study, number one, are emergency healthcare frontliner more confident after attending COVID SAS training? Does the COVID SAS training alleviate anxiety among the emergency healthcare frontliner? What are the areas that can be improved from COVID SAS training? And is the COVID SAS guidelines sufficient in handling a suspected COVID-19 case? So my general objective is to explore our emergency healthcare frontliner perception regarding COVID SAS training in resuscitating a suspected COVID-19 patient. Specific objectives are addressed as below, which is number one, to evaluate emergency healthcare frontliner confidence level in resuscitating a suspected COVID-19 patient post-training. Number two, to explore any anxiety among the emergency healthcare frontliner in clinical environment that is susceptible to COVID-19, which is our emergency department. And number three, to assess emergency frontliner perception of risk, knowledge of preventive measures, and also infection control measures. And number four, to evaluate the sufficiency of COVID SLS guideline that we have devised. So my my methodology, we conducted an exploratory qualitative study in our emergency department in Hospital Tuanku Hospital Chancellor Tuanku Mukhris. 20 emergency healthcare frontliner who have underwent COVID-SS training are recruited. Then we divided them into groups and we conducted a face-to-face focus group interviews, which took about like 30 to 45 minutes for each station using interview protocol. So the study was conducted from October 2020 to January this year, and the exclusion criteria would be emergency healthcare frontliner who couldn't present for the interview, who refused to participate in the study, and who have not completed the COVID-SS training. So this is the workflow of my study. So we obtained a full list of emergency healthcare frontliner working in Hospital Chancellor Tuanku Mukhris Emergency Department. Then we identify the potential eligible candidates using purposeful sampling. Then we invited them and then given their appointment for the interview. And also, like, once they consented, then we will conduct the face-to-face group interviews. Okay, inclusion criteria are all who are working in emergency department during the study period and those who have completed our COVID-SCOS training. This is the questionnaires that we use to assist us in our data collection when we're conducting our interview. So we explore their perceptions by using these 5 questions, which address like, does this training enhance your confidence in handling COVID-19 cases, and we can probe further in what aspects, knowledge, skills. Number 2, does this training reduce your anxiety in handling COVID-19 cases? What aspect of your anxiety? And what is your future plan to improve your knowledge and skills? What areas of improvement that they can provide us? What make you better after attending COVID-SCS training, like, and why? And the final question is, how are the guidelines of this training can help you in handling COVID-19 cases? This guideline is clear, easy to understand, how to improve them so it can be used more easily by all healthcare workers in the future. So this is the steps that this is the flow that I approached to analyze my data. So we recorded the interview, we transcribed verbatim into the interview into English. And also like and validated by 2 specialists, and then we analyze the transcription using thematic coding. From the thematic coding, then we identify meaningful units and create a category, and subsequently develop like themes according to these categories, which I will present later also. So a little bit of demographic for my participants. My participants are 20. Their age group, majority of them are aging around 31 to 35 years old. Then the youngest will, 31 to 35 years old. Female predominant, and then like majority. Then the occupation would be like 4 of them are staff nurses, 6 of them are like medical assistants, and the other 10 will be medical officers. Majority of them have working experience of like 6 to 10 years, and most of them are married. So this is the table, a concise table that has summarized my result, and I've divided them into 4 themes, which according to my research questions that I mentioned earlier, whereby we are interested in the participants' confidence level, their anxieties, any area of improvement for the COVID-SCLS, and whether these COVID-SCLS do they deem it sufficient or not. So we'll go through them one by one, very, very brief. Confidence level, all of the participants mentioned that they have acquired new knowledge, and this have boost up their confidence in handling the suspected COVID patients after attending the COVID-SCLS training. So they
JB, sorry to interrupt. You have 5 minutes.
How many minutes?
Yes, 5 minutes. 5 minutes.
Okay, sorry. So in that case, I will move on very, very fast. So from that table, then we can our discussion is that we address that knowledge and awareness. All the participants have acquired knowledge and awareness to manage COVID-19, and this is also supported by these 2 studies, Bhagavatula, whereby they said because of the significant knowledge gap between doctors and other healthcare frontliner, this will lead them to ignore or not adhere to protocols. So knowledge is very important. And then the concerns of safety among healthcare workers, all of them express anxiety because of the safety. And then this is also supported by these few studies. Okay, then simulation, they think that simulation training is the best teaching tool. This is what is approached by the conventional AHA and ACLS course. And then these few studies also mentioned that scenario-based and simulation training are better training tool to teach a new knowledge for the participants. So, and then the mental health among healthcare frontliner in the pandemic setting, majority of them have the high rates of depressive symptoms, anxiety, insomnia, and distress. 14.5% of them screen positive for anxiety. Then what else? Okay, one of the suggestions provided by the participants was that they encourage this COVID SLS to be repetitive and to have more sessions. And this is also supported by these few studies whereby they said repeated short courses may help to maintain knowledge and provide opportunity to learn without endangering the patient. And then the mean score reported lower after training, possibly due to lack of regular practice, which is why we want to emphasize that the repetitive training is actually very important. And in order to compensate for that, video teaching can be used as a new learning tool. And the video can be as short as 30 seconds or 30 to 60 seconds. And it has been proven that can improve the quality, responsiveness, and long-term retention of knowledge. So we were criticized in our study that our guidelines was not very clear. So, but in this study by Kelly et al., they mentioned that physicians are actually very overwhelmed by healthcare advice during human influenza outbreak because of excessive information. Okay, so last but not least, our limitation is actually due to social distancing and also self-protection protocol. All our participants have to adhere to standard protocol by wearing face masks. But as you know, in qualitative study, we actually need to interpret participants' facial expression. But because of the face mask, this actually impeded us. We cannot really know like what they are feeling, how is their expression. And another thing is that many people, especially Asians, we are all very shy. We are not very camera friendly. They feel uneasy knowing that they are recorded. So when a participant is not comfortable, they are prone to provide ideal answer instead of what they are truly feeling. So finally, our conclusion is COVID SLS does hold a benefiting purpose to all emergency healthcare frontliner by building up confidence level through teaching new knowledge. This also relieves anxiety of safety and fear of transmitting the virus to surrounding people. Area of improvements include regular training sessions, adopting other teaching modalities, and incorporating better equipments. Our flaw identified in this study is that the COVID SLS is too brief, the course duration is too brief, and unsatisfactory reading materials. So with that, thank you so much. Sorry for the time constraint and also the rapid speech. Thank you. Okay.
Okay, Jabi, thank you. You ended just on time, actually. It's 10:30 right now.
Thank you so much.
Yeah. Okay, so we have Dr. Joy Regina up next. Dr. Joy, are you there?
Yes, sir.
Okay, magandang araw po. Good morning.
Good morning, magandang araw sa'yo. Magandang umaga.
Okay, Dr. Joy, you have 20 minutes. Take it away.
I'm Dr. Joy Regina Lactupo. I'm going to present my research entitled Confidence and Willingness of Healthcare Personnel of Emergency Department in Tertiary Hospital in Manila to respond to public health emergencies. My co-author is Dr. April Janeta. Natural and man-made emergencies occur due to recently emerging diseases and outbreaks and terror attacks. Healthcare professionals are expected to respond immediately during these emergencies. There is a need to recognize the situation, confidence, and willingness to respond of healthcare personnel during emergencies. For the significance of the study, the Philippine General Hospital is a tertiary hospital governed by the University of the Philippines, Manila. As the hospital with the greatest number of specialty and subspecialty programs, it is designated receiving hospital in times of public health emergencies, such as during mass gathering or large events. PGH is considered the end referral with patients coming from various institutions and agencies. It is a challenge for hospitals to continue providing health services when circumstances involving public emergencies arise. Frontline healthcare personnel in emergency department settings are expected to continue to do their tasks and serve patients even when they are supposed to be looking into the welfare of their own families and during disaster and public emergencies. Through this study, we can characterize the risk perception of healthcare personnel, their concerns and issues about their own safety and that of their families. Preparedness plans can then be evaluated and changes instituted so the hospital can better respond to any public health emergency. For the general objectives, are the healthcare personnel of the Philippine General Hospital in the emergency department willing and can confidently perform their tasks in the event of public health emergency? Specific objectives, number 1, to describe the socio-demographic profile of healthcare personnel of the emergency department that will respond to weather-related radioactive dispersal device emergencies. Number 2, to describe the limit barrier of confidence and willingness of healthcare personnel of the emergency department to report on duty during weather-related or radioactive dispersal emergencies. Number 3, to determine the the emergency emergencies in important duty in times of weather-related or radioactive dispersal device emergency in the context of the following instances, if asked but not required and regardless of its severity. The study setting of the emergency medicine, the research study setting is in the emergency department, the Philippine General Hospital. It was a 2 months duration. The study design is a cross-sectional, conducted administered survey developed by the Center of Public Health Preparedness of the Johns Hopkins Bloomberg School of Public Health. And the samples healthcare personnel randomly selected from either rotating residents, ER nurses, and EMTs.
Sorry, Dr. Joy. Sorry to interrupt you.
Yes.
Can I make a suggestion for you to turn off your camera for the time being because it slows down the presentation. I think there's like it takes up the internet. So I would suggest you just turn off your camera first, and then turn it on later during the Q&A session. Would that be okay?
Yes. Okay. Sorry, I thought it was off.
Oh no, it's on. Okay. Thank you.
Okay. Okay. Hello, where did I stop? For the result in object number 1, socio-demographic profiles, based on the result of the study, respondents showed that most of participants are age group of 20 to 29, comprises of 42%. Majority of are females, and most of them were Roman Catholic, which is 77%. More than have been working in the hospital between 1 year to 5 years, and 111 have been serving as resident for 2 years. Based on the study, the limit and barrier of confidence and willingness of healthcare personnel of the emergency department to report on duty, the top factor would prevent them in fulfilling their duties are fear and concern for families and self. During a weather-related, it's 82% compared to radioactive device emergencies. And transfer service to from and work are the top factors that assist them in fulfilling their duties. Most of the personnel consider availability of care services for elderly and children to be important during weather-related than during RDD emergencies. Provision of protective gear at top factor assist personnel to fulfill duties, weather-related emergencies at 92% compared to radioactive device emergencies. These graphs show that the occurrence of RDD emergencies perceived to be 26% lower than the weather-related emergency. However, 1% more people perceive that radioactive dispersal device events to cause a severe death consequence. Majority of the cases is 88% device emergencies, which is 89%. For the objective number 4, willingness to report on duty, it showed that more personnel are willing to respond during a weather-related emergency than during an RDD event. 66% if they are required to do so, regardless of its severity. 69% are willing to report on duty on a weather-related event compared to 49% during RDD. To analyze, a model can also be built to determine the impact factors to willingness and confidence of healthcare personnel to respond during emergencies. Inferential analysis, other than tests of association, can help to generalize the result to a greater population than only doing descriptive study. Therefore, my conclusion, in the midst of public health emergency, the healthcare workers has a vital role in responding during the incident. Frontline healthcare personnel of Philippine General Hospital are confident and willing to respond when the need arises, provided they are well protected and more knowledgeable through series of seminars, tabletop exercise, course training, or full-skill drill exercise. Based on the survey for both weather-related event and radioactive dispersal device emergencies, the following recommended to build the confidence of healthcare personnel to respond: provide adequate transportation to and from work for both commuters and non-commuters and alike. Free hospital shuttle services must be made available where and when needed. Healthcare personnel can be picked up from their homes or in the agreed fixed designated areas around Metro Manila. Provide comfortable quarters within the confines of the hospital or within its vicinity for those hospital personnel who will opt to stay instead of going back to their respective home. Ensure the utmost safety of everyone for institutionalizing and strictly observing the hospital protocols, such as but not limited to wearing of PPEs, and conducting diagnostic tests at no cost to the hospital personnel regardless. Number 4, ensure the high level of knowledge and preparedness of all hospital personnel, conserved by regularly conducting seminars or symposia, as well as hands-on trainings to improve the skills and sets of the first responders. And the last, provide supplementary in terms of food supplies or monetary for extra compensation for your extra expenses. Terima kasih. Thank you.
Okay, that was a nice surprise, Dr. Joy. Sama-sama. That means you're welcome in Malay.
Okay.
Sorry. Once again, I would like to ask both the presenters and the two judges to have their cameras open. Prof. Haldun also, I guess, if you intend to ask questions. Okay, let's take a look at Dr. Kevin's video.
Good morning to all the panels and all the participants. First, I would like to thank the organizer of the EMSS to invite me to present my thesis presentation. First, I would like to introduce myself. My name is Kevin Wong, and I'm the final year in emergency medicine training in Hospital Chancellor Tuanku Muris in UKM. And the supervisor of my research is Professor Dr. Ahmad Khaldun Ismail, with the co-supervisor Dr. Ida and also Dr. Sarah. This is the Gantt chart of my research, and this research starts from 2019 in June until up to this year in February. This is the overview of my research, or the roadmap of my research, starting with the finding the research question all the way until submission to journal for publication. So first is regarding the research question. So my supervisor taught me this thing. What is research all about? And research is about finding the missing link in the string of knowledge. And the question that I have in mind that time is that whether house officer, or shortly HO, which is also known as intern, will be sent to district hospital as medical officer after they finish the housemanship training. And are they ready to manage airway and perform rapid sequence intubation as a medical officer? So in the session 13 2 of the Medical Act of 1971 in Malaysia stated that the fresh medical graduate shall undergo further training for the purpose of obtaining experience as a health officer with a provisional registration. And RSI is one of the procedural skills that health officers need to learn during their training. It is an important life-saving procedure in emergency department. So the problem is that there is no standardized training for health officer in Malaysia. The knowledge and skill to perform RSI should be acquired when health officer had their training in ED before they become medical officer. So does the ED of HCTM provide training and adequate clinical exposure so that the health officer who had completed the training will not only be confident but also competent in performing RSI in the future? So for all the research, we can go through this PICO approach, which is short form for problem, intervention, comparison, and also outcome. So first is the problem. For my research, the problem is, are the health officers confident and competent to perform rapid sequence intubation? Although this is not a RCT, not really an intervention per se, but the houseman did went through a 3-month ED training in HCTM, and the comparison is the before and after the training in our emergency department. And the outcome we want to look into is whether any improvement in confidence, knowledge, and skill. And this is my research topic, the evaluation of the confidence and competency level of health officer in rapid sequence intubation, or shortly as called RSI. So next is searching the literature. So when we come to literature in a research, this is the 5 questions that we need to answer actually. Number 1, why is this topic important? Number 2, what is already known on this topic? Number 3, what question this study addressed? Number 4, what this study added to our knowledge? And lastly, how this knowledge is relevant to clinical practice. So first thing first, why is this topic important? This topic is important because RSI is a life-saving procedure, and all the health officer who are going to become medical officer need to be competent to perform this procedure. And previously, other literature have reviewed regarding the intubation skill. Example, Fatil et al. Had done a study among the emergency training in ED of HCTM, noted that majority of the staff, which is the service medical officer and also the EM trainees, are competent in performing rapid sequence intubation. However, a study by Chan et al. To assess the adequacy of the undergrad clinical skill training noted that about 45% of the health officer are not very satisfied with their training, and 42% of their supervisor feel that their training is poor. Last but not least, Salah et al. Noted that the about 40% of the medical graduates from UKM themselves feel that they are only not fully confident in performing the intubation procedures. So what these studies try to address is whether to evaluate the confidence and competency level of the health officer after they completed the training in ED HCTM. And this knowledge is important, is to help us to understand whether the ED of HCTM provide adequate training and clinical exposure in rapid sequence intubation. And this will be relevant to our clinical practice in terms of training, so that in the future, our department will know how to guide the teaching and the training of house officer for housemen in rapid sequence intubation. So this is my research questions. Are the house officer confident and competent in performing RSI after training in ED of HCTM? And whether there's an improvement in confidence and knowledge level of house officer in rapid sequence intubation after training in ED of HCTM? The general objective is to evaluate the confidence and competency level of health officer in rapid sequence intubation after training in our ED. And these are the specific objectives. Number one, to determine the improvement in confidence and also knowledge level of HO in RSI. Number two, to evaluate the confidence level of house officer to perform RSI by using a questionnaire with the Likert scale of 1 to 5. Thirdly is to evaluate the knowledge level in performing RSI, and we assess it by using a set of MCQs. And lastly, to evaluate the skill level of house officer in performing rapid sequence intubation after training in ED by using a OSCE and checklist. And this will be further explained in the methodology of the studies. So the hypothesis that we have at that time is that house officers are confident and competent in knowledge and skill of RSI after training in ED of HCTN, and there will be improvement in confidence and knowledge level of house officer in RSI after training in our ED. So next, getting into the details of the research. This is the methodology of my research. So this is a prospective cross-sectional studies done in the Immunology Department of HCTM UKM over the period of 12 months. And the population of our interest is the house officer in our Immunology Department. And the calculated sample size using Kretzy and Morgan table is a sample size of 44. The inclusion criteria is the house officer who have entered the training in ED of HCTM and they have consented for the studies. The exclusion criteria will be those house officers who have done the training and working in other emergency department. This is the flowchart of my studies. So first, the invitation will be forwarded to the house officer, and they will be recruited into the studies if they consented. And there will be two phases of my studies. The first phase is before they start their training in ED. So immediately when they enter into the department, they'll be recruited and go through a pre-test by doing a set of questionnaire. 3 months later, which will be the second phase of my studies, then there will be a post-test after 3 months of training in our ED. So there will be a set of questionnaire, and in addition to that, there will be a OSCE. So there's a few study tools in my research. The first one is a questionnaire. So this set of questionnaire divided into 3 sessions, session A, B, and C. Session A is a 7 question regarding the demographic data of the participants. And session B is to assess the confidence level of the participants by using 12 statements, and each statement contains a 5-point Likert scale with the scale 1 of strongly disagree as the lowest, and also 5 strongly agree as the highest point. Session C is a 20 multiple choice question to assess the participant knowledge in RSI, and the total score will be converted into a percentage. And they are considered competent in knowledge if they score 80% and above. And this similar questionnaire will be done for the pre-test and the post-test. This questionnaire will be validated of the content by 3 emergency physicians of HCTN, and the first validation done by 10 house officers whether they understand each question in the questionnaire. And these 10 house officers were not included in the studies. Internal consistency reliability analysis was done with SPSS, and the combat alpha showed that it reached the acceptable reliability with the combat alpha score of 0.9. Second is the OSCE scenario and checklist. So all the participants will undergo OSCE with a standard OSCE scenario where the participant need to perform RSI on the airway mannequin with an assistant. And 2 examiners who are the emergency physician of HCTM will be the examiner to assess the participant using a standardized OSCE checklist. And there will be a global rating of either non-satisfactory, satisfactory, or good. And they are considered competent in skill if they're able to score good or satisfactory. And this OSCE was only done for the post-test because for the pre-test, this is not done because in other department in the training as a house officer, they rarely have chance or experience to perform rapid sequence intubation. So we assume their skill level is 0 or minimal. Next, this research was sent to our ethics department to get it approval. And next is the data collection time. So the problem, a small problem that I encountered during my data collection is that my data collection started back in around March of 2020. And this is the time where the COVID strikes the whole world and Malaysia was also affected. So initially my questionnaire was a hard copy printed in paper actually, but because of the concern that it can become a medium of transmission of the coronavirus, so that time I take the flexibility to change it into a digital copy using the Google form. And these changes was approved by our ethics also. And the advantage is that it is paperless, it reduces the virus transmission, and also Google form will automatically mark the result of the MCQ. After collection of the data, so now we need to analyze them. And this is the result that we have. So for the knowledge component, the mean score of the MCQ for the pre-test is around 43% only. But 3 months later, for the post-test, the mean score is around 74%, which is a huge increment. And the p-value shows that this is statistically significant. For the confidence level, there will be 12 statements regarding their confidence in rapid sequence intubation. And for the pre-test, the median score is around 2 to 3. Post-test is around improvement, show that the median score is around 3 to 4. And it is also statistically significant. Lastly is the skill level, where it will be using the global rating of the OSCE. Around 43% have a satisfactory score, and another 22% is good. They got a good for their global rating. So actually, about 65% of them are considered competence in skills. So some of the discussion or the observation that we observed during these studies. So we noted that our house officer has limited chance to intubate real patient. And this is because during this COVID pandemic was coincide with my studies. And during this pandemic, there's a change of SOP, and most of the housemen, they are not allowed to work in the respiratory, so in the resuscitation area. So subsequently, they can only have chance to intubate the non-respiratory patient actually, and this largely reduce the chance for them to intubate real patient. And also, we noticed that the house officer training are not uniform because they started the timing of the posting differently. Some enter earlier in the beginning of the year, some enter in the middle of the years. And the bedside teaching depends on the own initiative and also depend on the initiative of the medical officer. However, this was further complicated by the busy shift and long working hour. Usually they work about 12 hours per day, and most of our shift is hectic loaded with a lot of patients. So this might reduce the chances for them to have a bedside teaching with the medical officer. Thirdly, we noticed that there's a large improvement in the knowledge level. This is possibly due to the training in our emergency department, and maybe also their own initiative to read out for this topic. And lastly, because all the house officers have gone through these DOPS, direct observation procedural skills, before the end of posting, so most of them, they are actually preparing for the DOPS also. Fourthly is the increase of the confidence level, and this is possibly due to the clinical exposure in ED, and also because some of them has an opportunity to have hands-on session in skill lab and also in the DOPS. And a study by Abdul Samad et al. Noted that healthcare workers with a longer length of service were showing better confidence. So the fact that they have working in our department for 3 months also is a factor that increase the confidence level. Other studies by Makwana and Toys et al. Makwana et al. Did a study for 50 interns, and they go through a training session including lectures and practice on mannequin. And the study show a similar result where there will be improvement of knowledge, confidence, and skill in error management. And Toy et al. Did a study on 24 medical students. And the intervention that they went through is a 6 4-hour training session on 4 procedural skills, namely the intubation, arc-line insertion, LP, and also CVL insertion. And the results show that there's an improvement in knowledge score and procedural checklist score for intubation after the training. So these two studies show us a similar result like the study that I did, where we noted that there's an improvement in knowledge and confidence level, and most of them are competent in skills in doing RSI. However, this research also has some limitation. First, this is a single center studies in a teaching university hospital, so the result might not be applicable in other centers or in other government hospitals. And the sample size is relatively small, about 44. And unfortunately, we do not have any data before the COVID pandemic for comparison. So we can't really gauge how COVID pandemic has affected the training of our house officer. So my recommendation for the future training is more studies can be done for the house officer regarding the retention of knowledge and skill in rapid sequence intubation, and whether there's any association between the type of training and the competency level that they achieve. And since the COVID pandemic, and we know that COVID-19 will be with us for a long time, so there need to be some optimization of the house officer training. So it can be done in several few ways. Example is using a pre-recorded video lecture so that the house officer will all experience the uniform teaching. And also our department can organize in-house airway courses for the house officer so that they have more hands-on experience. And also they can have more practical session and also simulation trainings. And of course, if it's also allocation of department funding for houseman training, so that they have more opportunity to train not only in airway management but also in other procedural skills. So the conclusion of my studies is studies show that after 3 months of posting in ED of HCTM, there was improvement in both knowledge and confidence level in rapid sequence intubation among the house officer. And most of them had medium to high level of knowledge in RSI, and majority are competent in skill of RSI. And these studies was actually changed into a journal manuscript and was submitted to Science Malaysia Journal of UKM. And these studies, this manuscript was accepted for publication. And hopefully by this year or next year, these studies will be published. And before I finish my presentation, I want to acknowledge these few important people who have helped a lot in my studies. First is my supervisor, Professor Khaldun, and also my co-supervisor, Dr. Ida and Dr. Sarah, who helped me a lot during the brainstorming and also preparation before the submission to the ethics. And also Puan Saada from our statistical department, who helped me a lot in analyzing the data. And of course, these 3 EPs, Dr. Dazlin, Dr. Ni Azlan, and Dr. Surya, who willing to spend their time to validate my questionnaire and also the OSCE checklist. And with that, I thank you.
Okay, so that will be the end of the 3 presentations during this session. We thank Dr. Kevin for his efforts in providing us with the pre-recorded video. Right, next on the itinerary, we have the Q&A session. I think Dr. Joy and Dr. Joy, you can open up your camera now. You can turn on your camera, and Dr. Jebi as well. And also Dr. Patrick Joseph and Dr. Hashim. Please turn on your cameras. Prof. Khaldun, I'd like to invite you to turn on your camera as well if you'd like to ask questions. Okay.
I have to be berkecuali because my student is in the presentation. But I will ask for the other two. Yes, okay. I have to be impartial.
Okay, all right, cool. Okay, we do not actually have any. Oh, okay. I think just to entertain the audience, JB, there was actually a question that was asked in the Q&A box, but let's just, is it okay we just answer the question again live? There's a question from one of the attendees, Francis Blanco.
Maybe we let our judges to ask the question first.
Oh, okay, sure.
Okay, hi JB. Can you hear me, JB?
Sorry, hi, morning. Accidentally mute my.
Okay, okay. Congratulations for your presentation. I think your topic is quite interesting and relevant to the current pandemic of COVID-19 as well as emergency medicine. But I would like to ask how, since your study is a qualitative study involving a focus group discussion, how do you limit influence biases between your respondents?
Response biases. We actually devised 5 questions that we strictly follow to the questionnaires that in order to obtain the kind of information that we want to get. Then biases in if the response is too oversaturated, we'll actually if we only we only acknowledge the result if the response is saturated. But if the response is only like just individual or just pertaining to just one responder, then we will omit it. We will not acknowledge it. We will think that it's a bias.
Okay. How do you deliver the question? I'm sure it's open-ended, right?
Yes.
All right.
Okay, Dr. Patrick or Prof. Khaldun, if you have any questions, you may field them.
Okay, good morning. I have a question with Dr. Jebi.
Yes.
Yeah, similar to Dr. Hashim, regarding the bias, the respondents were grouped into 5 and they were asked for a group interview. Is that the methodology? Yes. Was there any influence from each of the participants to say the same thing as the others responded to the questions? Did you have any observation regarding that? Because sometimes when you are in a group, sometimes people tend to copy or do the same or answer the same question, have the same answers because they are afraid to have discordant answers or a different answer for that matter.
Thank you, Dr. Patrick.
Yeah.
Oh, sorry, interrupt. Did you finish your question?
Yes.
Okay. Thank you, Dr. Patrick, for your question. In fact, I do observe that phenomena whereby like when the participants are in a bigger group, especially my biggest group is actually 5 of them. So they tend to, when the first participant actually mentioned about something, the others tend to head to the same direction and they tend to give the same response. I think it's because that they have some pressure. They are pressured to provide the same. They're pressured to voice out what they really think. Number 1, and number 2, maybe it's because of the recording that they make them feel uneasy about it. That's why.
Thank you. Another question is that why did you choose to have a qualitative rather than a quantitative approach in such a manner that the intervention is a COVID ACLS? Is that the intervention that you're doing in this study? Were you thinking of having a pre-interview and a post-interview, or what was it intended just a post-interview after the intervention?
Okay. My study was done after the COVID ACLS training was done, and for whichever that participant has consented, we'll recruit them. The reason why qualitative study was adapted instead of quantitative is because we believe that when we conduct a qualitative study, we can actually explore further instead of providing them an objective areas that we wish to know. So but in a qualitative, we can actually explore what is a subjective manner. So we can actually explore like what the participant really like want us to be aware of instead of what we want to gain from them. So I think instead of giving an objective measurement to really say that the COVID ACLS is sufficient, we should actually not forgetting about any other areas that are out of our concerns and out of our interest that is actually important for the participants as well. So in short, instead of evaluate the COVID ACLS objectively, we are also trying to approach it subjectively to the participants. So in order to improve the COVID ACLS law.
Thank you.
Did you bridge any gap from your study?
Sorry, Dr. Hashim, can rephrase that question? Bridge any gap meaning? Sorry.
Yeah, did your study bridge any gap?
Bridge any gap?
I mean, in terms of your area, your research statement.
Bridge any gap? I believe no, but I'm not too sure. I believe no.
All right. So what is your motivation for further study then?
My motivation for further study. As we know, actually Malaysia is actually quite blessed from pandemics all this while. If you recall from my global pandemic timeline, we never participated in any of the pandemic. But unfortunately, this time we are involved in COVID. So I think everyone took it like very in shock and not very well prepared. But if we able to, if my how to say, but once we have, since we're involved right now, I hope that my study can serve as a framework that for future pandemic we will not be caught off-handed, and we can use this as like a reference or a framework to further help in tackling the future pandemics. So this is my motivation, Chair.
Okay. Thank you, Gabby.
Thank you.
I have a question for Dr. Joy. Yeah, congratulations again for your presentation. Okay. I didn't get, is there any limitation from your study? Tak ada dah. Dr. Joy.
I think Dr. Joy isn't online anymore. The internet, maybe having problems with the internet, but she's not with us anymore. If she comes back, we can field the questions again to her. Yeah, she's not in the Zoom anymore. Okay, sorry for
any
that.
question from the chat for Dr. Jackie? Or
okay,
you want to field?
Okay, yes, there is one question in the Q&A box, but before I get to that, I would like also to remind the audience, because there was one audience member by the name of Pintaka Rini. She's raising her hand to ask a question, but I'd like to remind the audience that they can only ask questions in the Q&A box. Okay, only the panelists and the moderator can ask them and ask the questions live. So everyone in the audience, please type your questions into the Q&A box. Okay, so we do have one question by one Francis Bon Blanco in the Q&A. Jebby, I actually already typed out the answer, but I think for entertainment's sake, let's just have Jebby answer the question again live. Okay, the question is, were you able to find a research on baseline learning curve of simulation training for COVID ACLS? Jebby?
Okay, the short answer is no, unfortunately, but the longer answer would be, since as we know, the conventional AHA ACLS course actually is incorporating like 2 full days. One day will be mainly the teaching, the hybrid teaching, video, and also the classroom teaching, and the other day will be the simulation training. So that is the conventional ACLS course. But in our COVID ACLS, actually, unfortunately, we couldn't afford that because we need all our manpower to tackle this pandemic. So we can only spare like 2 or 3 hours to train our emergency staff. But by hoping so, we are actually hoping that we are actually building on top that our emergency staff has already like the knowledge of ACLS, and we are just teaching them the new things about AGP and how to protect themselves in dealing with a suspected COVID-19 patient. So unfortunately, no, I could not find any literature about the baseline learning curve. But this is something that we should take. We are aware also, and also from our participants' feedback, feedback, and what we can what we can improve from this is that we provide short videos about 30 to 60 seconds in the future, and hope that it can make them learn better, and also for providing longer retention of knowledge. So the short answer is no. I'm so sorry.
Okay, thanks, Jebby, for answering that question again live. We have Dr. Joy Regina back with us, actually. So, Dr. Joy, one of the judges had a question for you.
Yes.
Yeah, but I think you dropped out of Zoom just now.
I have a question because I didn't get any limitation from your studies.
My limitations in my studies was that the nurses from the ICU and other anesthesiast doctor is not included in my studies. Only the emergency nurses, emergency department nurses, the doctors or resident rotating in the emergency department, and then the EMT, that's included. And also the OB/GYN residents and doctors are not included in my studies.
So Dr. Joy, your study is a single center, yeah? It's only one. Has it been reproduced from other places yet?
Sorry?
Is your study only single center, only on your center, or is there a combination of other hospitals?
Yeah. It's only in in the Philippines, it's only in the Philippine General Hospital, but my questionnaire was adapted from the Johns Hopkins Bloomberg Public Hospitals, and the questionnaire was adapted in our setting in the Philippines.
Is there any changes required for the adoption of the questionnaire to your local setting?
Yeah, just only about the weather, since the Asian is not snow on, where we don't have any snow, and then just the weather, and then actually the questionnaire, it was 3 scenarios. My study was conducted prior to pandemic. It's just so unlucky that I drop the infectious scenario. That's why it's not included in my research.
All right.
Okay. Thank you, Dr. Joy.
Thank you.
We still have ample time until the end of the Q&A session.
I think if the other judges have any other questions for Dr. Kevin, maybe they can field the questions. Maybe Dr. Kevin can respond later in writing.
Judges, if you have any questions, or even the audience, actually, if there's questions from the audience.
Okay, maybe can end.
Okay. Dr. Pat. Okay. Dr. Hashim and Dr. Patrick, if you don't have any more questions, we don't have. Also, you can ask actually the audience watching on Facebook. We're streaming this to Facebook on the Faculty Perubatan UKM Facebook page. You can also comment ask your questions in the comment box there. Dr. Patrick, you have any questions? You have any further questions?
I think I have one question with Dr. Joy.
Okay.
Yes.
Because your study was done prior to pandemic. What do you think can be an offshoot from your research, since we are on a different disaster right now? And are they still willing to? Do you think the willingness of the nurses and doctors are still there despite this pandemic?
As what I saw in the present setting of the Philippine General Hospital, the health frontliners are still willing to go on duties, though sometimes since the pandemic it's almost been 2 years, and then I think they reach under burnout. So I think now there are some limits. Some of them are actually have been resigned since the year ongoing of pandemic.
Would be interesting to have a follow-up study on the current responders, and see how it is, and you can have a baseline to compare with during these 2 years of pandemic and the result from your study. So that would be an interesting follow-up, I think.
Yes, given a chance. Thank you.
Yeah.
Thank you.
Thank you.
Okay, we any other questions? I think the presenters can ask each other questions as well. I don't think it would be wrong to do that. Okay. Oh, there's a. Oh, apparently one of the panelists for judge for the next session actually raised his hand, Dr. Emmanuel. Yeah, you can just turn on your camera and mic, Dr. Emmanuel.
Yeah. Good morning, everyone. So I believe I myself is a public health emergency advocate here in the Philippines. So I would like to ask Dr. Joy, or I hope that since your study is very interesting, and possibly or probably you may consider in your future studies to involve all ED personnel, because since public health emergency is in a perspective of an emergency medicine physician, entails an all hazards approach, meaning to say there is no particular personnel in your area who will respond. So there will come a time that you will be the one who will be the first responder. So possibly that's an avenue for next researchers to other EM physicians to consider not just a single department, but try to consider also the perspective or the willingness also to other departments if they could help in the event of emergencies and worse in the disaster. Since public health emergency is not only for fire or earthquake, but it may be a surge or a mass casualty incident.
Yes.
Okay, that's all.
Thank you.
Thank you, Dr. Emmanuel. Actually, you know, if panelists from other sessions want to ask from, you know, not from the current session, want to ask questions like Dr. Emmanuel did just now, that's fine as well. For after this. Okay. There's no more questions from the audience in the Q&A box.
We can end and
okay.
break.
Okay, I think if we're satisfied, we can go to the break now. So it's time. We'll just end the Q&A session now, and we will gather back at 11:55. 11:30. Okay, so we'll take a 15. What time is it now? Yeah, we'll take a 5-minute break. Sorry, take a 5-minute break, and then we'll come back for the third session at 11:30 Malaysian and Philippine time and 10:30 Indonesian time. Okay, thank you.
Okay, welcome back to our last session. The presenters this time are Dr. James Patrick Gado from the University of Philippines and Dr. Muhammad Nakib from University Kebangsaan Malaysia. The judges for this session are Dr. Emmanuel Gallo and Dr. Vayuni Dian Purwati. Dr. Emmanuel is the emergency medicine consultant in the Corazon Loshim Montalibano Memorial Regional Hospital, Philippines. He is also the public health emergency and disaster manager, while our lovely Dr. Vayuni is the emergency physician in Siloam Hospital, Kelapa Dua, Banten. Gentle reminder to the audience, you might type up your questions as you listen. Please also state who you intend the question to be answered by. To the presenters, please stay until the end of the Q&A session. Dr. James, the floor is yours.
Sorry, we come. Hello, good morning. I am Dr. James Patrick Gador. I will be presenting my research entitled Nasal Carriage of Medicillin-Resistant Staphylococcus aureus among Healthcare Workers of University of the Philippines, Philippine General Hospital Department, Emergency Department. For the introduction, staphylococci are ubiquitous human parasites. It colonizes the anterior nares of asymptomatic carriers who may unknowingly transmit the pathogen within the community or within the healthcare facilities. Emergence of the drug-resistant strain, especially methicillin-resistant Staphylococcus aureus, is a serious problem both in the community and hospital environment. Currently, MRSA is considered a major cause of healthcare-associated infections. Persistent carriage could act as a reservoir for infection, and healthcare workers have been implicated as source in a number of published outbreak or reports. It is presumed that in general, healthcare workers are more likely to be colonized than persons in the general populations because of the increased exposure. For the statement of the problem, what is the prevalence of the nasal carriage of methicillin-resistant Staphylococcus aureus among healthcare workers of the University of the Philippines, Philippine General Hospital in the emergency department? This study aims to determine the MRSA nasal carriage rate among the nurses and residents, physicians of the UPPGH emergency department where different kinds of patients are encountered. For the objective of the study, specifically, it aims to determine which group of participants has the highest MRSA nasal carriage rate and to determine the presence of risk factors associated with MRSA colonization among the healthcare workers. For the methodology of the study used descriptive cross-sectional research designed to determine the nasal carriage rate of MRSA among the staff nurses and residents physicians of UPPGH Department of Emergency Medicine from August to December 2019. Target population, the study involved the total population of nurses and emergency resident doctors of UPPGH emergency department using total enumeration sampling. The data were collected over the period of 5 months from August 1 to December 31, 2019. The clinical specimens were cultured and the organisms isolated were subjected to antimicrobial susceptibility testing. Methods of specimen collection, processing, and antimicrobial susceptibility testing were based on the quality control procedures specified by the Clinical Laboratory Standards Institute. This is the study flow. Mannitol salt agar, a selected media of differential media, was used as a primary screening for Staphylococcus aureus. Presence of yellow colonies surrounded by the yellow halo or change in color of the media from orange to yellow is indicative for Staphylococcus aureus, which is a mannitol fermenter. Colonies that are mannitol fermenter were subjected to tube coagulase for the test confirmation. The tube coagulase test was used as a confirmatory test for the identification of the Staphylococcus aureus. Positive result on the tube coagulase confirms the growth of Staph aureus and further subjected to the susceptibility testing following Kirby-Bauer disc diffusion method. The methicillin resistant was screened by the disc diffusion method using MH agar with 1 microgram oxacillin disc. After 24 hours of incubation, each MH plate was examined. If the zone of inhibition is equal to or less than 10 millimeter in diameter, the isolates were considered as MRSA. For the results and discussions, the total number of staff, nurses, and residents at the ER was 89. However, there were only 51 healthcare workers who participated in the study. In order to meet the study objectives, a total of 51 healthcare workers were purposely sampled from UPPGH Emergency Department. Based on the findings, the study, 21.56% isolates were positive for Staph aureus, 36.8% or 7 among residents were positive for Staph aureus, and 12.5% or 4 among nurses. In another study conducted in the nasal carriage of Staphylococcus aureus among the pediatric healthcare workers in the pediatric ICU, there were 7.7% nasal carriage of Staph aureus, which is 3 lesser than compared to the current data gathered. This table shows the distribution of Staph aureus strains among healthcare workers at UPPGH Emergency Department. Among the 51 healthcare workers, 5 or 9.8% were positive for MRSA. 3 were found among residents and 2 among nurses. There were 11.76% or MSSA positive, 5.8 88% among both residents and nurses. In the study in PGH in 2012, none of the 7.7% Staphylococcus aureus isolates was MRSA positive. To date, the investigation done in PGH is the most recent available study published locally that deals with the MRSA nasal carriage among healthcare workers. In 2011, Kumar et al. did nasal swab at 84 healthcare workers in tertiary hospitals in India, and nasal carriage of MRSA was observed to be 21.4%. 83.3% among doctors and 16.6% among laboratory technicians. The prevalence study is similar to our study wherein there is a higher prevalence among medical doctors. However, in another study, prevalence study of 965 hospital workers who were screened, the highest rate of carriers was found in the clinical ward staff at 9%. Nursing staff were more likely to be test positive than medical staff, 9.6 versus 6.3%, more or less. This could be attributed to the nature of the duties and also the other risk factors that could be present among them. In this figure shows the history of skin infection within the past 3 months among MSSA and MRSA nasal carriers. The skin infections included skin abscess, carbuncles, folliculitis, and other, which were more likely caused by Staph aureus. Among the MSSA nasal carriers, there are 6 had no history of skin infection. And among MRSA nasal carriers, there are 1 of them each had history of folliculitis. History of previous skin infection has been correlated with the increased risk for MRSA nasal carriage. However, in this study, there were more MRSA nasal carriers who had no previous skin infection. The history of antibiotic use for the past 3 months among those who are Staph aureus and non-Staph aureus nasal carriers is shown in this figure. In the group of MRSA nasal carriers, 40% or 2 of them had history of antibiotic intake, while 60% or 3 did not take any antibiotic. In the group of MSSA and non-Staphylococcus aureus nasal carriers, there were 33.3% and 30% respectively had a previous antibiotic use. Among the MRSA nasal carriers, there is greater percentage of those who had no history of antibiotic use, in contrast with some literatures which showed correlation of the different kinds of antibiotics such as penicillins or macrolides and fluoroquinolones. Exposure in infected individual is one of the risk factors that predispose healthcare workers to MRSA, like in this situation when they had direct contact with the suspected staphylococcal infected patients. Based on the results, all of the healthcare workers, carriers, and non-carriers had history of exposure with the staphylococcal infected patient for the past 3 months. In my conclusion, MRSA is persistent and growing problem in the healthcare institution. This study showed that 21.56% of the 51 healthcare workers in UPPGH emergency department are Staphylococcus carriers, in which 9.8 were MRSA nasal carriers and 11.76% were MSSA carriers. MRSA nasal carriers has been observed both among residents, physician, and nurses with 5.88% and 3.92% respectively. Known risk factors for MRSA colonization were present to the MRSA positive group, such as history of skin infection, antibiotic use, exposure of the infected patient. For my recommendation, the development of intervention control measures in arresting the spread of MRSA associated with infection in the hospital is highly recommended. It is recommended that rigorous screening of all healthcare workers, especially those who are in close with the patient, be included during their annual medical exam as part of the control measures in order to monitor the MRSA carriage. For future studies, the researchers recommends a further correlational study or associated risk factors and MRSA nasal carriage. The identification of the other risk factors that could be correlated with the MRSA carriage among healthcare workers is also suggested. Thank you for listening.
Okay, thank you, Dr. James. Dr. Nakib, you may proceed with your presentation. Thank you.
Hi, Assalamualaikum and good afternoon. My name is Nakib Sulaiman from Emergency Department, Hospital Chancellor Tunku Mukris. Thank you and welcome to all our respected physicians, doctors from Philippines, Indonesia and Malaysia. Okay, now I would like to deliver my studies regarding the prevalence and factor associated with decision to discharge patient from non-critical zone of Emergency Department, Hospital Chancellor Tunku Mukris. My supervisor is Dr. Dazlin Basniana binti Sabardin, and the co-supervisor is Dr. Afiza binti Abu Bakar. Okay, this is my outline of presentation. I will talk about the introduction, a little bit of literature review, research question, objective of study, methodology results, discussion and reference. Okay, basically my study is focused on triage, and we are talking about the triage process. As we know, the triage is very important because it's make a priority and urgency of the treatments. And the correct classification is very important because, as we know, under triage can cause a delay of diagnosis and treatment and lead to the mortality and morbidity. So in Malaysia, the under triage rate is only 0.5% only. And as we know, the triage, the dynamic process, so the assessment and the evaluation of patients is very important to detect any deterioration which lead patient to the triage to the higher care of level. So my focus today, we want to explain to understanding the factor associated with decision to triage, because the studies show that the patient water sign are significant factors in prediction of the risk of triaging. However, there's still limitation. So that's why we explore by furthering of my studies. Okay, now for the little bit touch on the literature review. As we know, triage is come from the French word trier, which means separating and categorizing, focus on the classification and prioritize patient according to the urgent of the treatment. So the correct classification is important. And then one of the studies showed that the water sign a significant factor for the triage patient. So most of the study mentioned regarding the elderly is more prone to the under triage. And also the other thing is non-specific complaint who are admitted to the ED will lead to the low quality diagnosis and leading to hospitalizations. Part of that, the decision making using the POCT can show the reduce and delay to the treatment and can improve the outcome of the patient. Part of that, regarding the environmental factors, they showed that the most patient who need to triage among the severe trauma patient is occurred at night and by the study of Nakahara. And part of that, there is no significant difference is under triage between working and public holiday according to the Ramahani study. So part of that, there are studies showed that the longer waiting times reflected in longer mean length of stay in emergency department, which associated with short term of death and admission in hospital as well. Okay, why we are we choose to further in study because we are a few research questions come to our mind. So what is the prevalence of triage patient among patient in non-critical zone of our department? Because before there's not explored yet. The second one is what is the patient factors associated with decision of triage, and what is the environment factors associated with patient of triage. So this will lead to our main objective to explore the prevalence and factor associated with decision of triage patient from non-critical zone. So the specific objective to determine the prevalence of triage patients, to determine the association factors and also the environmental factors decision to triage patient. So we come with the research hypothesis, which is there is association between the patient factors and also the environmental factors with the decision of the triage patient from non-critical zone of ED and CTM. This is methodology of my studies. This was prospective observational study with quantitative approach which performed to the medical hospital record. So the study site is our emergency department, Hospital Chancellor Tunku Mukris. The study was conducted last year from 20 June 2020 to 26 September 2020. It's about 3-month period of data collection. And then the study population is all patients who were triaged from non-critical zone during the study of the period. Okay, this is just one image to introduce this in my emergency department's location, which the study have been involved in the study. Okay, the methodology for the inclusion criteria, all patient is seen in non-critical zone and decided to triage after seen by doctors who included the criteria. The sample size based on the formula by Daniel 1999 the total patient who were included in studies is about 288 patients was included in study. Okay, this is the diagram show the flow of the patient who come to emergency department, triage from the primary and secondary triage. The patient was seen by the doctors in non-critical zone. For those patients who we encounter have the criteria who fulfill the unstable patient or having the danger criteria, we considered to be up triage. And then those patients who have objectively to send to the non-semi-critical or critical zone based on patient factor and emergency factors will be up triage also. So we will look for any possibility of the factor associated with decision of triage in this study. So the flow is patient who's seen in a medical non-critical zone will be identified from the patient SIM assessment form, and then we will trace the patient's file and get the complete data based on the medical record, and then we will fill up the form, and also the data entity analysis will be done using the SPSS. So we have analyzed our data using the SPSS, and then we compared the patient who had been admission to the ward and discharged after being up triage to look for the univariate analysis using the student t-test and Mike-Winnie test for the continuous variable, and also we compared using the chi-square and feature test using the category key variable depend on distribution of the data. So now we focus on the result of the patient. During the period of data collection, there were total about 7,120 attendance to the non-critical zone, and then the prevalence of up-triage patients about is 4.04%, equal to 288. Among the up-triage patients, about 80.5%, which is 232 patients who admitted to the ward. So this is a demographic data. So most of the patient is about male, and then the Malay is the majority patients. Patient who have the diabetic mellitus, the majority have the comorbid in these studies. So hypertension. So the most common chief complaint is specific chief complaint, which is included GI and also fever as the main presentation symptom of chief complaint, and the vital signs as mentioned on the slide. Okay, I want to focus about the admitting diagnosis because it's related to our discussions. So the most admission diagnosis is was the infections is about 43%, and then when we do the sub-analysis, we noted that the dengue fever with warning sign is about 43% was the most common diagnosis among infection group who been up triage and admitted after that. So when we compare the two groups, admission and discharge group after being up triage, so we are looking for the which factors that have significant p-value to determine what is the factor that can be directed or can be used as the prediction factors. So the first one is age, which is the p-value is 0.008, and the higher age is admission group compared to the discharge group. The second one is present of comorbid, which is diabetic, hypertension, and also dyslipidemia, which lead to the probability to admit to the ward after being up triage. And then the fourth one is about the systolic blood pressure and also diastolic blood pressure, which is lower in the admission group compared to discharge group. And the next one is the temperature higher in admission group compared to the discharge group, who lead to the admission after being up triage from non-critical zone. And for the system evolved, the majority is about fever, who lead to admissions is about significant 0.05. And then the using of POCT, which is the blood gases in admission group, we show that higher compared to discharge group in using the utilization of the POCT. For the reason of up triage, we noted there was two reasons. There was for monitor the patient and also for give the treatment. Will lead to the admission compared to discharge after being up triage with the significant p-value 0.04 for both of them. For the environmental factors of up triage, the significant in the unit analysis is about shift of attendance, which is show that the AM shift about 0.05% for admission group, and also the number of doctors in non-critical zone during that time is 0.01%. So after we get a few data, few factors, so we proceed with multivariate analysis to look for the most significant factors in triage patient. So there are few of them showed that significant, which is a fever with 0.03, systolic blood pressure is 0.01, and then the temperature is 0.02, monitoring and treatment is 0.03. So in this data for the environmental factors, doesn't show the significant p-value when we done our multiple logistic regression. So we are going to discuss regarding the discussion. So as conclusion, our prevalence of triage is only 4.04%, and the commonest reason is by monitoring and treatment. And then when we look our data, so actually our patient actually was triaged accurately because our under triage percentage in this study is only 0.01%. So we look for the patient may be possibility triage to the higher triage group if we're using the 5-tier triage system compared to our practice now is 3-tier triage system. So your study compared to ESI, Emergency Severity Index, who practice 5-tier system compared to our Malaysian triage category who triage system, show that ESI is more specific and sensitive with lower under and over triage rate. So we are looking the accuracy of ESI found that under triage rate for low acuity patient was only 80%, which initially tries to the ESI4 demonstrated the higher prevalence of admission. So for the factors to answer our second research questions, so the most of our triage patient is fever, come as presenting complaint, were admitted with the diagnosis of dengue fever with warning sign. So they required hydration and monitoring. And then as a study by the Subramaniam, fever was the most common reason patient come to the ED, and also have the high predictive of the in-hospital admission. So they are also correlate with fever with a clinical of infection. So patient have to perform further investigation and start early treatment, and will lead to the hospital admission after being triage. The second one is regarding the age. As we know, the increased age will have the higher odds of admission. So risk for under triage and also patient in elderly associated with adverse outcome that impact the admission decision. For the vital sign, the lower blood pressure have the higher associated with admission. So the reason we uptest the patient to monitor the blood pressure, and usually the doctors is more confident to discharge patient in those who have the normal blood pressure compared to the low blood pressure. So there are studies show that the low blood pressure also associated with poor outcome in emergency department. So for using of the POCT, usually we use most commonly is venous blood gas. Show that we reduce the time of initiation of treatment, and if any abnormality in blood gases will indicate the patient is need longer treatment and need beside the to be admission by physician. So example, the patient have the high lactate will present in impact tissue perfusion. So they will reduce the therapeutic turnaround time and short the door clinical decision for admission. So for the reason of triage, monitoring patient and commencing treatment are two significant factors in my studies. Then will lead to patient to be admitted. So as mentioned by study by Table Chan, that patient requiring ongoing therapy in ED is increase of the admission compared to those who are observed in investigation. So when patient we decide early in our non-critical zone for observe and treatment, so it's considered a warning sign for the patient, which lead to the admission after being triage. For the environmental factor, unfortunately, our study showed there is no significant association with admission rate, which a contrast to study showed that by Goodman noted that the longer waiting time associated with greater risk in admissions, and part of that different outcome may be because of different study, which is in our studies is only involve one center compared to the study by the Goodman involve the cohort study for all emergency department in the country. So the association with ED shift also has not significant association with admission rate in this study. So the limitation and recommendation of my study, because we are conducted in only one hospital, teaching hospital, so it's maybe have the limitation to transfer the study results to other hospitals. Part of that, the short duration, about 3 months, maybe may not represent the whole year process of the triage in our emergency department. So for the study, to establish tool and guideline for the up-triage patient may result in development and more rapid symptom approach. So as conclusion, the prevalence of after-triage patients is only 4%. The patient who have the association, patient factor had the association with decision to up-triage. The finding provide information for better understanding in up-triage process and may improve the patient care. So this is my reference, and that's all. Thank you.
Okay, thank you to all presenters. We will now open up the Q&A session. Boleh buka dengan Prof tak? To all the judges, do you have any question for our presenters?
Where will we start? Good afternoon. Good noon. Can we start asking now?
Yes, please.
Okay. To Dr. Gador, I believe this study was conducted 5 months pre-pandemic.
Yes.
Okay. So what do you think your research may contribute to the current pandemic situation, especially one of your sampling is nasal, providing a nasal specimen. So what might be the implication of your research to the current pandemic situation?
So in my research, probably significance of my research, probably the methods. Siyempre kasi the methods of testing COVID-19 is also a nasal swab. Then COVID-19 and MRSA, the mode of transmission they are both different. The MRSA is direct to direct skin contact, while the COVID-19 is airborne or droplet. So for the significance of this study, probably the recommendation, I recommend that in times of pandemic, probably we should do a routine, standard routine of nasal swab for our healthcare workers, such as residents or nurses or the NA maybe, so that we can document or note the result or the who will be the infected by the COVID-19, and we can also correlate this documentation to other research, such as if there is any risk factors or any comorbidities that would trigger much more mild or moderate disease.
Okay. So you mentioned the risk factors, or you have mentioned on your presentation the correlation. That's why you chose the previous antibiotic use. What else? The skin infection and the other one? I understand you mentioned the 3 strong correlation of having this nasal carriage of MRSA, but what do you think might be the other mode of exposure of these healthcare workers being infected with MRSA, aside from these 3?
Maybe direct contact with the patients, such as their fomites like pillow or bed sheets, or if the nurses do their nursing care, if the patient is already had an MRSA, then probably there will be an increased risk for infection for that nurse that handle the patient.
Okay, so I believe your research entails total enumeration sampling.
Yes.
Okay, so were you able to provide consent or appraisal before conducting the study or before introducing your study to your prospects?
Yes. The research was voluntary, and there is a questionnaire and a consent form for the procedure, and unfortunately, there are 89 population in the ER, but only 51 volunteers had signed the consent. That's why
Okay, so I
51.
believe you said that you have the total enumeration sampling supposed to be 89.
Yes.
And you mentioned in your presentation, I believe 29 out of that 89 did not participate. So what might be the possible reason? Why is it they are reluctant or hesitant to have nasal sampling?
So prior to pandemic kasi ito, so that's some of the nurses, probably more nurses, they did not consented because they were afraid that if they had tested positive, they will get leave or something, or parang they were afraid that they will lose their job, something like that. That's why.
But I believe you have mentioned on your discussion that the 29, and there is no adverse event or untoward incident happened during the sampling to those who consented with obtaining the nasal specimen. So my last question is, since this is also, you mentioned the prevalence studies. So within the Philippines, so you did mention previous studies of having these nasal sampling to lab technicians. So had there been any previous studies wherein the research environment is within the emergency department?
There, in the Philippines, there is none, except for in the UP PGH pediatric ICU department, where the staff nurses were tested for Staphylococcus only, but not MRSA. There is one journal also I saw in the National Kidney Center here in the Philippines, in the ICU naman. They only tested for Staph aureus only, but no MRSA testing was done.
Okay, so congratulations for your study. So we hope that there is some follow-up, or they will follow your recommendation to have further studies in relation to this research. Okay, so thank you.
Thank you, sir.
Dr. Gador, may I ask you a question? Yes. Congratulations for the study. This is very interesting. I just want to ask, is there any specific reason why you choose the population from the emergency department? Not, I mean that we know that MRS actually can be infected not only for people or doctors and nurses that working in the emergency department, but also in the high risk area like in the ICU. Do you have any specific reason?
Yeah. For this reason, when I was a resident in the emergency department, I always saw non-healing foot patient, or there are plenty of them. Then we were very in contact with them. Then there are very crowded. They were very crowded in the hospital in the area. So I take an idea that maybe we have to do a nasal swab to determine that maybe we are carriers. That's why we have plenty of patients like this. That's why we have plenty of patients that had folliculitis or carbuncles. That time, kasi prior to pandemic, there were an event in my residency that I have many cases. I have many cases that had skin infection like carbuncles, non-healing wound patients. that's why I came up with that idea. And also in the situation in the ER, they were very crowded. Then also the hygiene that time were not very standard. That's why so I did the research.
Okay. How busy is the emergency department? How crowded?
Our emergency department that time, we had only 150 bed capacity, but the patient inside the area prior to pandemic, we had 500 to 1,000 patients in the area. That's what, so it's very crowded. But now we have the new ED, and also we had very spacious area na. So probably the area was bigger enough to the patients we catered to from now.
Okay. Then what is your recommendations related to the MRSA, to the emergency staff, or for the head ED? What's your recommendation?
Probably I will recommend to conduct another correlated studies for this MRSA, and also I will recommend to have a standard or screening for every staff, nurses or doctors in the ER, or not in the ER only, or in the whole department, maybe every 6 months, so that we can gather data, and probably we can use that data to make another research for correlation studies. But now probably COVID-19 is very more
okay. And how will you make you say that the participants is very low, right? Because some of the nurses are very afraid to come and join. And do you have any idea related to this? Maybe next research, when you're doing the research, they will not afraid again?
Maybe my recommendation, maybe when you conduct this research, you should partner with the infectious disease in the hospital, so that they can disseminate the idea or the research. Kasi kung if ever the infectious disease department would do the instructions, they maybe had less fear, something like that. That's why if as less fear, and also they will think that if it's a standard protocol, that's why so they cannot be or we'll make it a compulsory, or maybe.
Okay, doctor. Almost same with Indonesians. Thank you very much.
Okay, so may I add with that your recommendation, since here in your study you're focused on the correlation study of those 3 factors. Perhaps you might also try to have another an avenue of research. It's interesting also of how frequent the healthcare workers, especially in high risk areas, do proper hand washing. Because sometimes you cannot deny the fact that us healthcare workers sometimes forgot to proper hand wash, or do hand sanitation and hygiene. That might be possibly a carrier. So since you did mention the infectious control involvement, it's part of your recommendation. Okay, so thank you, Dr. Gador, for that.
Maybe I have one comment for Dr. Gador. Is that okay? Yeah, just to follow up from Dr. Wayuni question. The normally as a staff, it's a new staff starting to join medical. It's a kind of a compulsory to check for status because it's involved patient's care. So staff need to be screened as a compulsory thing when they're starting, and that includes your TB, your TB status, your MRSA as well, doing swabs. I experienced myself when I worked in the hospital in Ireland. Before starting, we always have to do checkup for new staff. And regarding the screening, I think doesn't have to be a regular thing for everyone. So if let's say you have an outbreak, a possible MRSA, then there's a possibility for those who are in that area of concern to be screened. So it doesn't have to involve all the staff in the hospital to be screened. So only, let's say, for example, emergency department or even some part of emergency department where you have regular staff working in that area. So those staffs are the one that is going to be screened based on the outbreak of MRSA in that area. So, so is there some sort of national policy in the Philippines, maybe for this?
For what I know, Doctor, there are no policy yet in this MRSA research and also here in the Philippines, in my experience, there are no nasal swab screening or any documentation have done in the other hospitals, and also in my hospital in PGH. The one that only had a documentation was last 2012 in the pediatric ICU of the PGH, and also in National Kidney Center in the Philippines last 2018. But there are no standard or any regulation about this.
Yeah, so that's where, if you notice, that's why we do the research.
Yes,
your research is important in that sense. It can actually, influence the policy making and the protocol development, the working flow with the infectious disease. So that's the importance of why we do research, or your research in a way. So all the best, I hope.
Thank you, Doc.
Any question for Dr. Nakib from judges?
Shall we proceed with Dr. Sulaiman? Or...
Yeah, any question for Dr. Sulaiman?
Dr. Sulaiman, I'm asking about why you choose up-triaging from the green zone to the semi-critical. Yeah, what is the reason?
Okay, thank you, Doctor. Because basically we are dealing with flow of patient which come from non-critical zone to our from semi-critical to non-critical, from non-critical to semi-critical zone. So we are dealing with the outcome. So they will ask, cross in my mind. So what's patient supposedly treat in non-critical zone but come to semi-critical zone? So I want to explore more because I want to know how is there any our mistriage of the patient, or is there any thing that we can improve later on when we manage patient in non-critical zone? So that's why I want to know the factors to make sure that after this we can make shorter decision to admission in non-critical, and also make the shorter time to decide for the treatment and also for observe the patient. So that's just want to explore the flow of triage process. We know this consider triage is dynamic. So when we go deep in this flow, so we can understand more and we can improve our triage process in our ED, especially in our UKM lah.
Okay, so I see from the thesis that there is a patient's factors and also the environment factors. Which one is the dominant? The factors, the factors come from the patients or the environment?
Okay, basically, when we talk about dealing treatment of patient, both of the patient, the fashion factors and environmental factors place factors regarding the outcome of the patient. So we anticipate that both of the factors should impact the decision or the result of the patient based on the triage. But based on our studies, we showed that the most dominant factors in triage patient is fashion factors by itself compared to the environment. because we are looking for the results, the age, the presence of the fever, the vital signs, display of the important when we decide to upcharge patient compared to evaluated factor like the waking hours or the shift of the patient. It doesn't impact much and not significant. So I can conclude based on our result, the more dominant in this study is patient factors.
Patient factors.
Yeah.
Okay. My one last question is related to the ED shift and the patient's admissions. You do the research in your own department, right?
Yeah.
Okay. So what is the correlations between the ED shifting and the patient's admissions? And what is the relationship with the upcharging?
Okay. So we anticipate initial when ED shift in our emergency department, the most patient come during the office hour, which is the AM shift. So we anticipate the longer waiting time in our non-critical zone. So lead to the patient have the instability and also the problem with the diagnosis will lead to triage. So initially we thinking that when patients are waiting a longer time, then in non-critical zone, especially for the AM shift, so patient have the chance need to be triage and admission. But after we get the results, we see there is no difference even the AM, PM, or night shift, which is not significantly have the difference in triage patient and admission and between among the shift itself.
Oh, so the research is only for patients coming with non-trauma, right?
Actually, our setting in non-critical zone, we put patient in trauma and non-trauma together, but we have the specific doctors in charge for trauma lane, but considered as non-critical zone also. So it's included also in our study.
Okay. Okay, thank you, Doctor.
Thank you.
Congratulations for the research. This is very interesting.
Yeah. Actually, your research, Dr. Sulaiman, is very interesting, but I would like to clarify or verify from you regarding your research. May I know what is your operational definition of triage in your study?
Okay, our operational definition is when patient, after seeking the treatment in low setting, which is a non-critical, after get the treatment and decide to transfer to the higher level of care, which is from non-critical to semi-critical or critical zone.
Okay. Since emergency department itself is a diverse environment, so there are a lot of triaging. We have pre-triaging for trauma patients. We have ambulance triaging. We have triaging before the patient come in. So may I know that, meaning to say that the patient is already inside the ED?
Yeah.
And okay. And you will up-triage him within the ED from non-critical to critical zone.
Yeah, Doctor.
Okay. So, since you did mention the semi-critical zone / critical zone, had there been any difference of using this terminology, or are there specific zone wherein you have the critical? You did mention from non-trauma to trauma, but your research environment, and you did total enumeration of your sampling, and your the research time for this is pandemic. So have there been any, can you describe us your semi-critical or critical zone?
Okay, doctors. For our emergency department, we divide to non-critical, semi-critical, and critical zone. For the other team, maybe they label as a green zone for non-critical, yellow for semi-critical, and for the resuscitation area, which is critical zone. So for the critical zone, for those patients who are from the initial triage, primary triage, who decide for any emergent resuscitation, like CPR, or patient was diagnosed with emergent life-threatening event like the myocardial infarction, so we straight away go to the critical zone. So after that, we have our 16 danger criteria in our department, which is those who have fulfilled any one of these criteria, who need semi-critical approach will go to the semi-critical area, or we call it yellow zone. So for those who are not fulfilled the criteria, will go to the non-critical zone. So regarding that, the division, we based on our policy triage in our setting itself.
So based on the outcome of your research, can you translate up triaging as one of under triaging or not?
Okay, we can, when we talk about the up triage, because we have list and explore, there are a few reasons of the up triage causes. Just only a few percent from the up triage cost is involved the under triage. So we can conclude when patient up triage because patient was under triage initially, because patient is hemodynamically is dynamic. Maybe patient come is correctly triaged because waiting hours, patient complaint changed that we detected after we encountered the patient. Then the patient is need for further monitoring and further immediate intervention, so need to up triage. So we doesn't conclude that up triage equal to under triage. It's maybe only sub causes of up triage process.
Okay, so may I know if had there been any studies related to your research in Malaysia?
Sorry, Doctor, can you repeat the question?
Had there been any studies that is related also to your research in Malaysia?
In Malaysia, when I encountered this study regarding up triage is not yet established. But for the outer country, there are few only regarding the up triage, like from one regarding the vital sign only. For the under triage part, it's a lot. So yeah, that's why I think it's up triage is not testing.
Yes, because I saw your introduction and I happened to scan the journal of study in Tehran, Iran. So the under triaging or up triaging. But you mentioned in your introduction the rate of under triaging in Malaysia is less than 0.5%.
Yeah. This one based on the audit in 2018. So they conclude that only low. But regarding the prevalence of up triage, so far in Malaysia is doesn't have yet now lah the studies. So that's why I think we start with level of our emergency department, and maybe later on we can expand more regarding the how about the Malaysians populations.
Okay, so congratulations with the research because it is interesting in the aspect of emergency department management. So congratulations and for the outcome of your research. So we learned a lot also. Thank you.
Thank you, Doctor.
I just have one small question. Just that in the study doesn't include those who are up triaged directly from the waiting area, right?
For those patients, we doesn't include because that patient usually the waiting hours is different. So this and then doesn't, because we talk about decision after patient seen in critical zone.
Yeah, because that's another area of interest, because that's the safety part where patient may be waiting for expendable time and patient can deteriorate while waiting. So that is another area where if you want to use a QA for your in terms of safety in emergency department quality assurance, that can be looked into as well, because if there are so many patients up triage direct from the waiting area, there must be something wrong with the initial triaging process or how we monitor patient while waiting for the green while waiting for to be seen by a doctor. Yeah. So okay, right. Yeah. Thank you.
Thank you, Prof.
Okay. Thank you for all the questions. Is there any question from the participants? Okay, if that's so, thank you. Seems like we are ahead of time. We will announce the best presenter from each session after this. For now, let's take 10 and please be back at 10:40 Malaysia and Philippines time and 11:30 Indonesian time. See you later.
Okay, so for the first session, again, we pitted Doctors Elise Wong and Dr. Farah Abdul Latif, and also Dr. Ahmed. The first session. Marianne, yeah, Dr. Marianne against each other in the first session, and I'm pleased to announce that the winner for that session is Dr. Marianne. Dr. Marianne Somera, congratulations. Okay, the second session, we had Dr. Jebby Yee from UKM, Dr. Joy Regina from the Philippines, and also we had Dr. Kevin Wong, who wasn't able to be here. So the winner for the second session turns out to be the absentee, Dr. Kevin Wong. So congratulations to him. And then the winner for the third session, which it was Dr. Nakib against Dr. James Patrick. Dr. Nakib won that session. Okay, so the three winners are Dr. Marianne, Dr. Kevin Wong, and Dr. Nakib. Congratulations to all the winners. So the prizes will be provided later by the organizers. We will keep in touch then. Okay, so that's before we close, I would like to invite Dr. Prof. Khaldun to give a few closing remarks, maybe just 1 to 2 minutes.
Okay, thank you so much. Congratulations to everybody who has participated. There is no true winner or loser in today's session. Everybody, from my perspective, is a winner because you have managed to complete your research and present. And some of you should consider publishing your research findings. That's the best way to really galvanize or put your efforts into something more tangible. So publication of research is the way to go. Don't just waste time doing research without publishing it. So share with the rest of the world your finding, and I hope it will benefit a lot of people. Okay, so congratulations to the so-called winners, I must say. Thank you so much for your efforts, and we can see today not just about the research itself, but also to build confidence in our young emergency physicians to present internationally, to speak, to prepare nice slides. We've seen a lot of good examples today, and I think a lot of people can learn from what's presented. Okay, so it's not just about research, but there are many other things along that include presentation, how you present yourself, how you speak, and so on. So these are all the things that we hope this EMSS research in emergency medicine, can put forward for the future as well. So again, thank you so much to the organizing committee, the secretariat, the moderators, and especially to the judges for your time and kind, attentive effort to listen to all of the presentation and to be here with us today. So with that, I thank you. Hope to see you in the next program of EMSS. Thank you.
Okay, thank you, Prof, for the closing remarks. I'd like to say congratulations again to everyone who presented. Everyone's a winner, and the whole. Okay, all right. Okay, thanks everyone. We'll now be displaying the. This applies to Malaysian audiences. We'll be displaying the QR code to get your MMA CPD points. That's it for today. We'll see you again next time. Thank you.
Thank you, everyone. Bye.